Good morning, everyone. You're all very welcome to the St. Patrick's Mental Health Services Remote Care Conference, a new era in mental health delivery. I hope you're all safe and warm wherever you are on this very cold morning and have lots of tea and coffee nearby. Today, we're exploring how investing in technology can improve choice, empowerment and efficiency in mental health service delivery. So throughout the morning and into the early afternoon, our speakers are going to discuss effective remote care delivery, looking specifically at St. Patrick's Mental Health Services Homecare service. They'll also be exploring the use of an online service user portal to underpin a human rights-based approach to mental health care by providing service users with access to their information. We'll also be discussing considerations around cybersecurity and privacy in the context of remote care, along with future trends in mental health and remote care. Shortly, we'll hear from some of the team at St. Patrick's Mental Health Services, including CEO Paul Gilligan, Medical Director Professor Paul Fearon, Director of Digital Health and Transformation Orla Gogarty, Digital Health Applications Programme Manager Frankie Prendergast, Clinical Nurse Manager Niamh Murphy, Chief Information Security Officer Ronan Devons, and Data Protection Officer John Woods. Later, we'll also hear from Krystian Fikert, CEO and founder of MyMind, which is Ireland's first and largest blended model of mental health care, and Lachlan Scott, the CEO of HealthLink, which provides accessible, free or low-cost mental health services. Finally, today, we'll finish with a panel discussion where we can chat through some of your questions and discuss future trends in mental health and remote care. And taking part in that panel discussion will be Professor Paul Fearon, Orla Gogarty, Krystian Fikert, Lachlan Scott, and Adrian Yates, who is a member of the St. Patrick's Mental Health Services Remote Care User Advisory Forum. If you have any questions throughout the event, please feel free to submit them through the Q&A box. And if you'd like to direct it to a specific member of our panel, just pop their name in with it and we'll do our best to get through as many of them as we can during the panel discussion. There likely won't be time in the body of the day to ask questions after each individual presentation, so we'll collate them for the end. If you have accessibility requirements, you could turn on closed captions by clicking on the live transcript function in your Zoom window. Final bit of housekeeping before we kick off. CPD certificates will automatically be sent to those attendees who registered for CPD when signing up for today's conference, but please do allow around 4 weeks for receipt of those. So let's get today started. To formally welcome you to today's conference, I'll hand you over to Paul Gilligan, Chief Executive of St. Patrick's Mental Health Services. Good morning, Paul.
Good morning, John. Thank you very much for hosting today. St. Patrick's Mental Health Services mission, ethos and services are grounded in a strong human rights framework. For the last 15 years, our strategies have really emphasised this principle. Human rights instruments cover a broad range of areas categorised under civil and political, economic, social and cultural rights. They include the rights to liberty, private and family life, freedom from torture, freedom from inhumane or degrading treatment or punishment, and the right to work, education, and the highest attainable standard of physical and mental health. There's absolutely no doubt that technology and remote care provide us with new and innovative ways to bolster many of the human rights obligations and principles that relate to mental health. The principles that are most relevant to mental health policy, legislation and practice in the digital health context include equality and social inclusion, the equalisation of opportunities and full inclusion within society of people experiencing mental health difficulties, personal autonomy and independence, promoting an individual's independence and ensuring they're given the opportunity to make decisions about their own care and treatment, least restrictive alternative proportionality when it comes to care. In other words, individuals experiencing mental health difficulties have the right to live and work in the community and to be treated and cared for in the community in which they live so far as possible. This includes the right to be treated in a least restrictive environment with the least restrictive or intrusive treatment appropriate to an individual's health needs and the need to protect others. And then lastly, provision of care on the basis of individual needs. An individual's treatment and care needs to be provided by qualified professional staff and needs to be based on an individually prescribed care plan that is discussed with the service user and regularly reviewed and revised as necessary. This includes the fact that treatment needs to be suited to the person's cultural background. I think it's clear that through embracing technology or remote care, we really have the opportunity to enhance human rights principles, particularly those of equality and social inclusion, autonomy, and proportionality. How do we do this? Well, if you think about it, number one, by bringing treatment and therapy directly to the service user, so right into their living room, so to speak. By addressing barriers to receiving care, such as where you live, what your transport needs are. I'm conscious, for example, today, if this conference was happening face-to-face, we'd have had to probably cancel it. Better facilitating a person continuing with their education, work, and social life. Providing an enhanced methodology for information gathering, utilization, and analysis, and sharing of clinical information, including between clinicians and with service users themselves. It also provides enhanced information capabilities to improve practice. And of course, it's the least restrictive form of care, providing choice and empowerment to service users. By providing our service users with an option to access care remotely, in addition to an option to access it in person, of course, we can further support and enhance their right to the highest attainable standards of mental health, allied with key human rights principles. With 3 years experience providing remote care options and seeing firsthand the benefits a remote service can offer, it could be argued, and certainly I think we will see it being argued in the future, that not providing service users with remote care options really infringes their human rights. In my view, there are a number of interdependent components required to ensure the successful delivery of high quality remote mental health care. These include an organisation that actively and openly embraces the possibilities of remote technologies to enhance a service user experience and which embeds remote care in its strategic plans. Secondly, clinicians committed to the principle of providing such care. Thirdly, ICT support professionals who understand the clinical power of technology and information. And fourthly, a communications department and a communications strategy that advocates for the value of remote services and really captures how providing the option of remote care is intrinsically linked to our human rights. Does it cost less to provide this care? No. Are there risks? Yes. Does it suit everybody? No. Providing remote care is no more costly than in-person care. The risks are relative to that. They're the same, and probably they're the same as that of providing in-person care. And clinician judgment combined with service user choice is usually sufficient to determine suitability. At St. Patrick's Mental Health Services, we are committed to the provision of the highest quality mental health care, and based on our experience over the last 3 years, we believe that remote care plays a significant role in supporting the delivery of high quality care. Our development of an electronic service user record, service user portal, Homecare, and other clinical remote care is a testimony to our fantastic staff across the entire organisation, clinical, ICT, admin, and communications. It's also a testimony to the service users who have engaged fully in this new approach and have trusted us with their care. And many of these staff that I talk about were involved in coming up with the idea of this conference today and organising, and I really want to thank them and Jan, who's been a fantastic supporter of St. Patrick's Mental Health Services. This conference is an opportunity to share learnings of developing remote services that are grounded in human rights and to highlight the role of enabling technology to deliver choice, empowerment, and efficiency in mental health service delivery. Digital technology connects us all, and by embracing remote mental health services, we open up to new possibilities, new ways to protect and enhance the human rights of our service users, and new ways to ensure we continue to offer our service users the highest quality mental health care services that are flexible and adaptable to their needs. Thank you for being part of this important conference.
Thank you, Paul. Thanks for that. Well, now we will move on, and I'm delighted to welcome Orla Gogarty, who's the Director of Digital Health and Transformation at St. Patrick's Mental Health Services. And I always think anyone who has transformation in their job title it just sounds class. I can imagine there's really brilliant stuff going on. So Orla is going to discuss the role of enabling technology in mental health service delivery. Good morning, Orla.
Good morning, Jan, and thanks for your introduction. And I wanted to thank Paul Gilligan as well for beautifully setting the context, the wider context, the international context and the human rights context. Hope you all can see me, can you?
Yes, perfectly.
That's grand. So I'm here to talk to you more specifically around the enabling technologies element of how we have implemented remote care. I have a number of slides that I'm going to talk you through, but essentially the story is about remote care can be delivered. We talk a lot in technology about the challenges and the barriers to implementation, but we wanted to talk about the success story at St. Pat's and other organizations that have implemented remote technologies and supporting access and choice and efficiency and empowerment, as Paul has mentioned, to service users. So I'm going to share my screen. Hopefully you can see that now. Is that available to you?
Perfect.
Okay, just going to put it on slide. All right, having some challenges putting on slide. Now, how's that?
Fab.
Okay, so as I said, we are going to talk about our journey in remote care. Paul has given you a little bit of wider context about our journey, but for those of you that don't know, St. Pat's, we are been around a while, since 1746 to be precise, founded by Jonathan Swift. We're the largest independent service, not-for-profit. We have three approved centres spread over 2 campuses in Dublin 8 and Lucan. We have at 750 staff, over 350 being clinicians, organised into multidisciplinary teams who provide care around various areas of specialty, from eating disorders to depression to addictions. We have 5 clinics which provide outpatient services and a wellness recovery centre that provides daycare. And obviously we've got here today to talk about remote care in the outpatient, day patient and home care context. As Paul has mentioned, we have a strong human rights-based approach to how we deliver care, and it permeates through all of our organizational operations. We have strong service user participation structures, and I'll reference those and how we engage the remote care advisory through the development of our remote care services. And we are a strong advocacy campaigner, and we have established a Centre for Mentally Healthy Living, which will include Academic Institute and the Centre for Innovation in Mental Health Technologies. And, you know, just to bring the story forward into the technology world, many of you will be familiar with some of these images that, you know, permeate our everyday life, from, you know, Fitbits to now video consultations, X-rays, portals, so on. And many of those technologies provide fabulous opportunities, but in order for them to realize real, true value to the service user and to the clinicians, they have to be integrated in a meaningful way so that the benefits that they bring are targeted. I'm going to talk to you about some of the background statistics we can see in the OECD, who looked at the implementation of telemedicine since the pandemic. And you can see, even though the story often about Ireland being a laggard, it shows that actually during the pandemic, we provided 60% of our citizens with access to telemedicine. Now, that's a narrow interpretation of what remote care is, but nonetheless, we were no longer the laggards during the pandemic. However, when it comes to electronic health records, even though this is a 2016 stat from OECD, we still have much work to do across many of our acute care hospitals. There's huge adoption of EHRs in GP practices, but in the acute care and the tertiary and secondary care services, we really have a lot of work to do, but it can be done. The remote care as part of a high quality service really has a number of drivers, including not just the service user expectations around choice of access, but also we can talk about the clinician shortfall worldwide, and offering remote working can give an employer opportunities to what they offer their employees and where and how they work. And of course, in the background across all of this is the health inflation costs, and how can we realize some of the cost efficiency benefits by the introduction of relevant and appropriate technologies. So we can see the pandemic and other health sector dynamics have accelerated the adoption of technologies into care, because we really needed to keep our service users and safe. So the strategic development of enabling technologies at SPMHS has its own stories, but there are two real strong pillars in how we want to approach this and have approached this. And that's ensuring the availability and security of our digital technologies. Availability means that it's performant, so that we have not just an EHR available, but the networks that support that to be available at all times is secure and performant. Also the organizational capacity, and this is not just the ICT team, but our organization and all staff across us have been absolutely fabulous over the last 6 years when we first went live with our EHR. And I really wanted to commend their flexibility and agility in developing new skills for work and new skills for clinical practice. So our focus over the next 5 years is going to be focusing on the flexibility that technologies can bring to service design and scalability, providing choice for service users and staff and how services are delivered and accessed, supporting access to information for service users, clinicians and research to make quality improvements to how we deliver care based on outcome measurement. And of course, the imperative around privacy and security, and not least, which is brought home by the recent, or the HSE cyber attack a number of years ago. So our focus is on choice, empowerment, and efficiencies. They're the three targeted benefits that we will continue to focus in on. The journey has been an interesting one. I'm in my position for 10 years this year, but the real journey around the technical modernization of our organization began in 2016, when we really brought in an EHR, which went live in September. We consolidated that in 2018 and actually had all of our mental health commission inspections enabled through the EHR, which was a fantastic milestone. And then in 2019, we brought in a patient billing system. We progressed in 2020 with the rapid deployment of the patient portal, which was necessitated by the pandemic. We wanted to enable our service users to have access to their own information. And then 2020, we brought in remote care services. The future really is focused on leveraging and optimizing the suite of technologies that we have, but also bringing in a focus around information security and cybersecurity, which my colleague Ronan Devons will speak about later on, and Frankie Prendergast, my colleague, will talk about the benefits that the portal has brought to service users as well. So yes, the compliance agenda has always been a part of what we need to deliver on as well. This diagram will be familiar to my colleagues in our ICT department. However, for those of you that do not come from a technical background, this is not to frighten you, but it's to really talk about what's behind the scenes in terms of technology. This is our ICT environment, and you can see a big black line which creates a box. Everything in the box is what we host, all the technology we host on the premises of our main campus, and everything outside the black box is hosted in the cloud. And we have a cloud-first strategy, which is bringing us to access applications that are protected in ISO standard data centers. And that's a really important part of our strategic direction and technology. So that's just to give you a little bit of context and background. However, the technologies for enabling remote care are more defined. I've mentioned our EHR, which we call internally as eSwift, our video consultation platform, which was really adopted at scale during the pandemic and Microsoft Teams. We rapidly deployed at an earlier stage our portal, which we call Your Portal, and we implemented a service user IT support service, which was really, we have a team of 3, which is a fantastic resource for the service users, but also for clinicians, where there may be technical issues or just a learning required for service users to access care online. And we can take the burden of those technical hitches away from the clinicians, who are really, their focus is about providing care. We also have an SMS service, which is tied into all of the above. And we have lots of other integrated technologies, which we won't be talking about today, but they're part of the suite of what we use to provide remote care. So the path to remote care for services, the enablers, as I've mentioned, has been a 5-year a preliminary 5-year investment program. So this did not come cheap. We made a strategic investment to invest in really important and suitable technologies from 2015 to 2020. During that period, we were maturing our digital capability, not just within the ICT team, but across the organization. And as Paul has referenced, we owe a great debt to the agility and flexibility of our staff to adopt new practices built around technologies. We are really grateful to our service user collaborative advisory structures, and they have been involved both from the start around the implementation of our portal. They helped us design and test and implement the portal in a way that was going to be adopted by service users in an easy way. And then that forum has transitioned into our remote care advisory, which really supported our approach to implementing remote care triggered by the pandemic. And of course, we work very closely with our clinical governance committee, and we really welcome and benefit from that collaborative approach as well. My colleague Frankie Prendergast sits on that forum. The triggering event for remote care, as many organizations experienced, was COVID, and the need to provide continuity of services to our service users. We could not afford to just drop off or drop out our services. Many and all of our service users rely on those, and many of them had the option of accessing from their home, which was fantastic. The outcome has been the introduction of Homecare, a transition to remote care in our outpatient and day programs, and the opportunity for staff and service users both to access care remotely, but to deliver care remotely, which has really been a game changer for many staff, and the rapid deployment of our portal, which is really embedded in our care pathways now. The maintaining factors in sustaining the integration of our technologies and how we deliver care is really about maintaining choice for our service users and how and where they access it. It's also about providing service users with access to their information. And again, we'll be talking about what your portal does in that area. The flexible working arrangement opportunities for staff, which we really want to maintain, and also the opportunities for new models of care, which the suite of technologies can provide. I want to thank my colleague Amanda Fitzpatrick, who is our program manager for health informatics, who put together some of this information. So really what you can see, this narrative in 2019, we had no group programs delivered remotely. We had a total of 35 CBT sessions delivered within a pilot structure in 2019. But following the pandemic, we introduced remote services from April, and during the course of that year, we implemented or delivered 19,000 individual appointments and 4,000 group programs. And that has built since that time over the years, culminating in last year when we're up to over 22,000 individual appointments and over 3,862 group programs. And there's been a somewhat mixed return to groups where service users do want to attend in person. And we are working through implementing suitable hybrid technologies to make optimal experience for mixed groups where people are attending remotely and in person. So the story around the portal registrations, which I've referenced, is a really critical part of our remote care suite of technologies. We implemented a rapid deployment in June of 2021, and we had a registration for that year of 777. And to date, we have over 2,000 service users who've registered to use their portal as part of their care and treatment. And Frankie will talk to you about some of the real key benefits to service users obtained from the portal. This is the front door, what it looks like. Frankie's going to go into far more details than that, but you can see that there's a huge range of functions and features that service user can access, both for themselves, but also to share with others, including their family and GP if they require. I'm going to finish off now talking about some of the unexpected challenges, because we can't just talk about benefits without talking about some of the tricky parts of implementing remote care. One of the unexpected challenges, but we wrapped our arms around it very quickly, was the need to provide technical support to our service users in real time. And so the establishment of our service user IT support has been a key pillar of that remote care service. The sufficient resourcing reference is not just about the money that it takes to invest in the actual hardware and software, but it's about the skills, the people and the skills and experience that they bring. People know that in internationally there is a real challenge in the technology roles market, and we've been very successful to date in attracting and retaining staff, and we have a fantastic team at St. Patrick's, but it's also out and beyond our own team as well, making sure that our staff have sufficient training and support to make sure that they can use the technology tools that they need to do their job. Managing complexity is really, as you can see from that previous diagram, we have a very complex technical environment that we need to manage and make sure that we do it in a structured and controlled way. We don't want to return to the world of shadow IT where everybody was doing a bit of what they want. There really needs to be a framework of information security and control. And Ronan Devon's my colleague, and John Woods, our data protection officer, is going to be speaking about the security and privacy challenges where you can't take your eye off the ball. And of course, we want to retain the benefits. There is a sort of a nostalgia about returning to the pre-COVID days and those in-person experiences, but to return completely would be deny the benefits that we really have experienced through this forced agility brought on by the pandemic. And really, that's really what the journey so far. I'm going to close off now and hand over back to Jan, and we'll, if you've got questions, we can either address them in the panel or you can pop them through later.
Thank you, Orla. That was great and really comprehensive, and great to go through all of the various different benefits and challenges as you highlighted them. Our next speaker is Professor Paul Fearon, who is Medical Director at St. Patrick's Mental Health Services. And Paul is going to discuss the home care service that was developed and delivered by St. Patrick's. Good morning to you, Paul.
Good morning, Jan, and good morning, everybody. And just while I do the most frightening part of a presentation nowadays, which is hoping that my slides share, can you just confirm that they're coming up?
Yes, they are indeed.
Right.
Yeah, all good.
Switch to full screen view. There we go. I'd like to thank Orla for organising this event, and also for inviting me to talk. So I'm going to talk for the next 25 minutes or so on our home care service. And what I'm going to do is I'm going to spend a few minutes, well, more than a few minutes actually, talking about the build-up, because this just didn't happen overnight, even though in one sense, because of COVID, it did. But there was a build-up which I'd like to take you through, because I think it's quite revealing. I talk a little bit about what is home care exactly, what the components of it are, and how we do it on a day-to-day basis. I talk a little bit about how it's embedded itself, if you like, into our service and the patterns of use over the last few years. And then I'll finish off by giving some feedback from the people who've used the service, because obviously that's critical in terms of whether this is a service that's that is acceptable to service users. And then I'll just have a final slide about the future. So as Paul has mentioned, and I won't dwell on it, but just to give you a sense of our service, we're the largest independent provider of mental health in Ireland. We have about 309 inpatient beds across 3 approved centres. That means we have about 10% of the national beds reside within our service. And we see about 1,000 new assessments in our Dean clinics, our outpatient service, and about 15,000 reviews annually. And we have a staff of about 700. So take us on the journey of how this developed, because if we go and all is mentioned about pre-COVID times, one of the things that we were very keen to do. Yes. I'm
very sorry to interrupt you just as you were heading into full flow, but your slides seem to have frozen. We're just still on the initial slide. So right. Probably the thing to do is to just reshare to kind of stop it and then reshare it. Oh, there we go. We're moving.
Okay,
we're moving. We're on the outline slide. Your slide number 2. We can see so there. That's the one you're wanting to be on.
Grand. Okay, so I'll try and okay. Let's see how this does. So what are you seeing now?
I'm seeing outline.
Okay,
slide number 2.
Okay, and you see it full screen?
No, if you just go up to slideshow in the top there, on the navigation bar, it's maybe 3 or 4 from the end in the orange ribbon.
Yeah, okay. What I'll do is, I don't mind, as long as people can see the main slide. I'll try.
Yes, we can. Yeah.
I think we'll carry on the way we are.
Perfect. Thank you.
So
Sorry for the
they're moving now. Thanks very much for that, Jan. So are we seeing those moving now? Yeah.
Perfect.
Right, excellent. Okay, so I'd just like to say a few words about our electronic health record, eSwift, that Orla has mentioned, because this was something, obviously COVID was in the future and nobody knew about it, but we wanted to move to an electronic health record as a more modern, accessible way to access our clinical records. And also we needed, because some of our record systems were already electronic, and we wanted to start to integrate those in a way. So these are just a few general points, because I was involved, as all will know, in helping to set up and implement eSwift. And for those of you who might be interested in setting up an electronic health record, first thing to say is that no product is absolutely perfect. You need to actually know what you want from electronic health record, and equally important, what bits you might be willing to sacrifice. But having said that, all EHRs, and this is probably the most important single thing about EHRs, is that all EHRs are better than paper. We went on a few field trips to other services in the UK and elsewhere who were using electronic health records, and we were always very interested in talking to the people who were perhaps not quite sold, or said, oh, it doesn't do this or it doesn't do that. But the question that was really revealing was, so would you go back to paper? And immediately said, God, no, it's so much better. One of the couple of the lessons that we learned, and in fact we preempted them, was that it's really important setting up an electronic health record that it's clinically informed and driven from the ground up. So in other words, you need clinician involvement. It shouldn't be just an IT department deciding what bits go in. You need to consult with staff before you start setting it up, while you're setting it up, and even then trialing it. That has so many benefits, both in terms of the quality of the EHR that you produce, and also in terms of buy-in, because obviously there'll be a point where you go from paper on one day to being electronic the next. So if people are familiar with it and have had input into it, it makes a heck of a difference. And we found the transition from paper to EHR smooth. And I think that was largely a result of that. It's also important to manage expectations. A lot of people think that an EHR is going to be really much quicker than paper. It's not really. There are a lot of efficiencies there, and incredible efficiencies. But I think it's important to be very truthful with people about what the benefits of it are, and what and to quash any ideas that it might do this when it actually doesn't. So we went live with our eSwift in September 2017. As I said, it was a pretty smooth transfer. The other thing to mention about EHRs is, once it's up and live, that's not the end of the story. In many ways, it's partly the beginning, but because you're going to be continually refining your EHR to optimize it, to add things into it. If certain legislation or a Mental Health Act changes, that needs to be incorporated. And that's reflected in the fact that we have a very active eSwift group still working in the hospital on a daily basis, working very hard to make sure it fulfills its functions. So we moved to sort of February 2020, which I'm sure we all still remember, and COVID hit. And we were faced with a situation where an independent sector provider, we needed to decide really quickly what our priorities were here. We knew that people were going to be having to isolate people, both service users and staff were likely going to need to isolate. So we needed to very quickly define what our priorities were. And they were the following. We wanted to protect, first and foremost, our service users and staff. We needed, while doing this, to continue treating as many people as needed our service. And for that, we needed to remain open and viable. And we needed to do this while upholding our human rights ethos and following all national guidelines around COVID. And as we remember, the challenges in particular were social distancing, reduced footfall, and managing outbreaks. And the four main elements for us that came together quite nicely were, number one, as I mentioned, our electronic health record. And immediately it became obvious the strengths of this, and it was just very fortuitous. First of all, it meant that staff could work from home. So if someone was asymptomatic but needed to isolate, they potentially could continue to work from home because they had access to the EHR on their secure laptop through a secure connection. And staff can actually provide care to patients in most settings. So both staff members and also service users could be in any particular setting, as long as they were joined, if you like, by the electronic health record. And also the other amazing thing was that, we knew this from the start, but it took on special significance during COVID, was the records were accessible from anywhere with the connection. And that really was a game changer for us. The other thing that we'd been introducing prior to COVID was remote technology. We'd been using Microsoft Teams prior to the pandemic. We'd been doing some CBT online, and the adolescent service was beginning to use it for certain things. So when the pandemic came, we were actually able to, and because of EHR, every clinician had access to a laptop, we were able to roll out Microsoft Teams on everybody's desktops pretty much overnight. We switched to meetings, remote meetings, pretty much instantaneously, and clinics and programs became 100% remotely delivered within a week or two. It took a lot of work, but we got there, because we remember back to COVID, you needed to be 1 or 2 days ahead of everything if you wanted to keep ahead of the COVID pandemic. We also were fortunate enough to have a separate campus, St. Edmundsbury, or now St. Patrick's, Lucan, a 52-bedded unit about 20 minutes away from this campus in James Street. And we decided to use this as our isolation unit, so that anybody who needed to isolate or who tested positive could be treated in a private ensuite room remotely until their period of isolation ended. That also meant that pretty much we could guarantee that St. Patrick's, the main St. Patrick's site, could remain free of COVID, because we could transport people over to St. Edmundsbury until their period of isolation had ended. We were able to use, and I'll come on to this in a moment, the remaining beds in St. Edmundsbury for our home care service. The other key thing, just to mention it, is that both for the EHR and for COVID, communication with staff at every step of the way was key. You need to communicate in a timely fashion, truthfully, about what's going on, and keep people up to speed. So let's talk a little bit about the home care service itself. At the time, we were faced with the dilemma: can we deliver the inpatient experience to people in their own homes? One of our challenges was, and it goes back to those principles about trying to continue to treat people viably, was what if people, quite understandably, are nervous about coming into a congregated setting for inpatient care? Is there a way that we can treat these people safely? So we sort of decided, what are the actual components of inpatient care, and can they be delivered remotely? And we decided that they could. Obviously, home care doesn't suit everybody, so it had to, the risk and the clinical profile needed to be appropriate, and more importantly, and equally importantly, indeed, people needed to be agreeable to home care. So we would explain, when we got referrals in, we would look to see, first of all, if they were clinically appropriate and if their risk profile allowed us to treat them remotely, and then we would discuss the home care service with them to see if they were willing and indeed wanted to do that. And if they did, then we would admit them on home care. We were very lucky that the three main insurers were I think they showed great wisdom because they were in the same difficulties all of us were in COVID, and they agreed to cover home care and indeed still do. They stipulated, and this was actually very useful for us, that we needed to retain a physical bed for each home care patient. For us, this was fine, because home care, as Orla again I think alluded to, and maybe Paul as well, home care is pretty intensive. It's just as intensive as treating a physical inpatient. So we're only resourced for a certain amount of inpatients. So having each of our home care patients assigned to a bed made sure that we were able to resource what we were treating. And at the height of the pandemic, during the long, severe lockdowns that we had in 20 and 21, we were treating up to 120 home care admissions at any one time. And at the moment, it's sort of, it's at about 70 or 80 at any one time of our 309 beds. And none of this would have been possible without the coming together of our electronic health record and remote technology. So what exactly is home care? I'm going to give a little bit of a sense of what it might be like to actually receive home care. So again, during the pandemic and over the last couple of years, the way we would do it would, as mentioned, we'd screen referrals for potential suitability on those criteria. And then if the treating team and the individual were agreeable, we would arrange admission. That would be done remotely over Microsoft Teams. So the full history and the full history mental state examination were performed, an initial care plan, medication was written up on our electronic health record. Obviously, there's certain things you can't do on home care. So a full physical examination isn't possible, and bloods aren't possible. So one needs to take that into account in accepting somebody for home care, or indeed if there might be an issue that comes to light during home care, to take steps to liaise either with primary care or else to consider whether a physical inpatient admission is more appropriate. And that person would then be assigned to a treating team in the same way as a physical admission would be, and an initial individual care plan would be formulated. It's evolved now a little bit, home care. We use it much more now for people who initially come in as a physical inpatient, and then once they've got to know the team a bit and their care plan is organised and things are going well, then they make the transition to home care, and that allows people to actually be at home to test out their care plan and any changes to that care plan in their home, in their natural setting. A little bit more about how it works on a day-to-day basis. So everybody who's on home care is seen at the main ward round at least weekly by their consultant and members of the team who attend the ward round, just like a physical patient. Allied health professional input is arranged as required, again, as it would be for any physically present patient. So that could be psychology, occupational therapy, social work, pharmacy. So if there's a need identified for any of these inputs, then that is arranged, and individual appointments are set up by the psychologist, for example, and the patient, and links to Microsoft Teams for those appointments are sent to the individual. And again, over and above that, again, to sort of reflect what might happen in an inpatient setting, all patients on home care are contacted at least once a day by a team member, and this includes weekend days, it includes Christmas Day, etc. So this is a 7 days a week, 365 service. Medications is obviously one of the tricky things. How do you prescribe for somebody on home care? Well, we've set up an arrangement which works pretty well, whereby we set up a link with the person's local pharmacy during the admission very early on, and any medication changes or any prescriptions are faxed to the pharmacy quickly, and then at their end, the patient or a representative of the patient picks up their medication, and that is. We've been doing that now for, as I said, the last 3 years, coming on to it now, and it works pretty well. I should mention the SUITS team, the Service User Information Technology Service, because obviously not everybody is set up for Microsoft Teams straight away. So we have a dedicated team to help people on home care to access and utilize their technology and to set them up on it so that it works well for them. And I say remote, and most people use take advantage of Microsoft Teams, but telephone is also available, and some people switch between the two. And I hope that slide is visible, but just to give a sense of the other activities that are available to people when they're in home care. There are daily activities. So there's a morning lecture every morning given by a member of staff on a particular topic related to clinical things. There's a weekly occupational therapy lecture, a social work lecture, dietetics. There's a daily morning anti-tension and indeed afternoon anti-tension. There's yoga most days, art therapy. There's an information cafe for people to mix and share and get information. And just in case weekly anti-tension isn't enough, there's also weekend anti-tension. So is home care been utilised? Because this was, in many ways, something that, even though we've been thinking about pre-COVID, we had to set it up fairly quickly, and we weren't sure, is this going to work? Are people going to want it? But just to give a sense of things, here's our annual use of home care over the last 3 years. I've included obviously 2020, but just from April to December, because that's when home care really started. And I've also chosen to include just the first 2 months of this year, just so it's bang up to date. I think there are a couple of things to note on this slide. And again, I hope you can see the figures. So straight away in that first year, the first 9 months of 2020, about 1/3 of our patients, or close to 1/3 of our patients, had their inpatient, if you like, in inverted commas, treatment via home care. Again, in 2021, that increased a little bit to 32%. We were still in the midst of the pandemic then. 2022 is interesting because, as you all know, we're kind of coming out of the pandemic, certainly in larger society. So we wondered, is home care going to be sustained? And the answer to that is pretty much yes. We're still running at about 29% of our of people choosing home care and home care being available to them, and that persists right through the first 2 months of this year. So it does seem to us that at the moment we're going through an interesting evolution where initially home care was set up as a response to COVID, but it's become now embedded in our service, and I think also in the minds of referrers and indeed service users themselves. People seem happy with home care. If we look at the adult service as opposed to everybody, and so I've excluded young people, our child and adolescent unit, then the numbers are pretty much the same. But if I go to the child and adolescent service, obviously the numbers are smaller. We have 16 places in our adolescent unit, Willow Grove, and so one of the questions we wondered was, how will young people and their parents respond to the opportunity of home care? And we didn't really know, but in fact the take-up has been really strong. As you can see, the numbers that take up home care are higher in the adolescent unit. There have been a couple of occasions even where 100% of the patients have been treated by home care. And I think there are probably a couple of reasons for this. I think younger people and their parents may not like to have to come into hospital. They like remaining at home. School holidays can often be a tricky time of the year. And indeed, we've noticed in the past admissions and referrals tend to dip over the summer holidays months. But now that home care is available, those dips aren't as evident, and people, I think, opt for home care. And I think also for younger people, it's very useful to, when they're trialing out maybe new styles of thinking or behaving or parts of the treatment plan, it makes a lot of sense to be doing it in their own home environment rather than the somewhat artificial environment of a hospital ward. So it's been one of the surprising kind of really successes of home care has been its take-up and its acceptability among younger people. In terms of feedback, because there's no point in setting up a service if people don't like it, and that goes for clinicians and service users. But we've done a survey every year, so we concentrated since 2020 on people who specifically receive home care. Now our response rate is modest, so we're talking for each year of about between 50 and 60 respondents. But bearing that in mind, first of all, in terms of the age profile of respondents, it's interesting that it's the response rate there's a response rate across the board, right from younger people right into the people in their 60s and beyond. Often there's this idea that somehow older people can't access or don't like technology. As a 58-year-old, I'm becoming increasingly irritated by that presumption. But you'll see that there's a good response rate from people who are in what we call middle age now. So getting on to some of these. So in terms of overall acceptability and use of technology, these aren't every single question because we asked a lot of questions, but I haven't cherry picked them. These are just to give a sense of the overall thrust of the findings. So for example, I found it was easy to access my care and treatment by video communications or phone. You'll see when we introduced home care originally, the numbers are pretty good, 75%. They increased in 2021, I suspect, as this became embedded and people got used to it. And it's remained up there at 87% in 2022. Similarly, I found using technology to access services to be convenient. Again, that started at a reasonably high level, 71%. It was 90% in 2021 and 76% in 2022. And looking at the quality of sound on phone calls or video calls being generally good. Again, it was at 79% in 2020, 92%, and then 85%. So these numbers have started well and increased reasonably as home care has progressed. And in terms of the impact of technology on care, again, a few more. I felt the use of video or telephone calls did not stop me from being able to express myself when talking to my team. Again, it was 65% in 2020, but it's around 72% now. So, pretty good overall acceptability. Similarly, using video did not stop me from understanding what was being said to me by the team. That currently stands at 84%. I had access to my medication, 83%. perhaps the most important ones in terms of overall use of home care. I felt any issues I had were addressed by my team, 81%, which compares very favourably with the same question for physical inpatients. I received regular calls from nursing staff, 87%. So you'll get the sort of the sense that overall the acceptability of this service is pretty good. If we look at the question overall, what was your experience of how hospital staff looked after you, which is, I suppose, a broad question that may address kind of satisfaction. And it was broken down. I won't go through each of them, you'll be glad to hear. But you'll see if you go to the right-hand column or any of the columns that regardless of the which domain of staff are being asked about, satisfaction with the experience of being looked after on home care by staff is very, very high. And apologies, this looks a little bit like a TripAdvisor rating, but when you merge average overall service user home care ratings, you'll see in 2020 the average rating was 6.7, and it's been 8.4 and 8.1 since. So pretty high overall ratings. Perhaps more telling, and it's really useful information for us, I suppose, in terms of service planning, is when we asked the question, would you consider the option of attending remote appointments in the future? When we asked that originally, I think about half of people attending home care said they would, but that's now increased to about 75%. So about 3/4 of people who experience home care are interested in considering the option of attending future appointments by remote means. And in terms of the future, I think, I mean, we've come through a journey with this. Home care is still evolving. I think we're clear now that home care wasn't just a temporary response to COVID. It's actually it now forms a part of the services we offer, and a major part of the services we offer, and we're very keen to continue that. It's an acceptable treatment option by those who experience it, and the majority of people who do experience it are open to the future use of remote care. So I could have written a lot about how it could evolve, but I'd rather you think about it in a sense, because it has a lot of possibilities. As I said, currently the way we're using it largely is for people who come into hospital initially physically. It allows their physical inpatient part of their spell of treatment to be shorter, the inpatient stay, and a lot of the work that they do afterwards is delivered by home care. But of course, there are other uses which we're still really sort of thinking about how to expand home care, and I think it's a service that is going to be with us now permanently. Unusually for me, I've actually gone slightly under time, but it's actually probably no harm, because Jan mentioned that I'm on the panel, but I'll be having to skip in and out of the panel due to other commitments. So I'm very happy if there are any questions to take them now. I'll just stop sharing for a moment and go to Q&A. Jan, I'll hand back to you. Thanks very much.
Thank you, Paul. That was really interesting, and it's as you know, I absolutely love when we're running under time. Oh, the other way around. But I actually had just one question just to ask you now, given that we have a little bit of time.
Yeah.
Where are we at in terms of, and it totally comes across from your presentation and from Orla's, the momentum that was required to keep moving forward to get this delivered, you know, when the pandemic was happening and when that sort of trigger event occurred. But how do you assess the impact of home care as a kind of a hybrid model, really, with inpatient in terms of treatment outcomes? Is there any research that's been done around in other jurisdictions or here?
There's actually remarkably little, because this particular model hasn't been replicated anywhere else in the same way that we do. I mean, we are currently looking at this. We haven't got results yet, but we do ask people every week to rate their and teams to rate their overall feeling of their improvement on a 5-point scale. So we're going to be collating that and see how it compares with inpatient work. Our overall feeling is that certainly on a broad sense, people are happy with the service. I know that's not the same as treatment outcomes, but the outcomes don't appear to be radically different. Now, of course, it's worth bearing in mind that the cohort of home care patients are specifics. That, if you like, there are certain groups of patients for whom home care isn't suitable. So somebody that's profoundly unwell, or actively and acutely psychotic, or somebody who may need, for example, ECT, or somebody who is acutely suicidal. These people would not be suitable for home care, and we wouldn't even consider it. So it's a slightly different cohort, so one needs to bear this in mind. But it's certainly something we're actively looking at, because it's something that's really important, that we produce outcomes for home care.
There's just one other question here. What do you think the future challenges are in maintaining home care as a service?
Yeah, I mean, I think there are a few challenges. I think we've, in many ways, when we started, it started so quickly that we saw it as an analog of inpatient care. And, you know, we still say you're admitted under home care, even though the person is at home. I think the challenge is going to be where it lands, and I think it can land in a few places that aren't mutually exclusive. I think it's for people to realize it isn't just a COVID response, and now that COVID is over, we go back sort of to just physical inpatient. I think it's just too great an opportunity. And I think that the fact that people who've experienced it are so enthusiastic about it, and that goes for many staff as well, you know, it works. But I think resourcing it and continuing to optimize in the same way as I mentioned about the EHR, the electronic health record, that you set it up, but that's the beginning of the journey. I think there's an evolution to be had in terms of home care. And I think that's very exciting. You know.
Somebody's just asking us here if you could share the daily activity slide again.
Sure, no problem. Okay, let's see if I can do it full screen, given that we won't be. So I'll share
if you can't, it's just really more to say about, you know, what some of the most effective activities that work particularly well when they're delivered remotely are.
Well, I don't think it's possible to say which specific, because everybody is different. So what may be the right one for me. So, for example, somebody who has primarily an anxiety disorder might find the yoga and the is that showing up full screen for you?
Yes. Well, no, but it's enough to be able to see it clearly. Yeah. No, that's fine.
For some people, it might be the yoga and the anti-tension groups. For others, it might be the occupational therapy or the dietetics lecture. So, I mean, the beauty of this is it's quite broad-based, and it's purposely broad-based so that because the home care group is quite a diverse group of people. Everybody's an individual, and also the diagnoses are across the spectrum. So we tried to capture what most people would benefit from regardless of their diagnosis, because you could argue that anti-tension is good for anybody. Yoga should be good for anybody, and information about occupational therapy, good diet, etc. So these are, I won't call them wellness, because that might lead me to the accusation of dumbing things down, which is wellness certainly isn't about, but it's to try and give people, apart from the specific inputs that they get from their team, general sort of advice and information about how to remain well after they've recovered.
I mean, I have to say personally, when I saw art therapy, I was thinking, but what if you don't have supplies at home? Like, what if you don't have good enough supplies in terms, or is the art therapy, you know, tailored towards more appreciating art, or, you know, how does that work? I realize you're not an art therapist.
I mean, art doesn't have to be an easel with oil paints and beside you and a beret. Art can be a piece of A4 paper and a few markers, or even a pencil or a bit of charcoal, whatever's around. You know, it's not really about the beauty of what you produce. You know, it's how you feel and how you interact, and you know, and everything else that goes with producing any art or any creation.
It's the act of creating. Okay, well, we're now. I don't want to completely, now that we were a little bit under time, totally jump it and eat up all of the buffer that we've created. So we'll leave it there, but thank you very much, Paul. That was really interesting, and thanks for taking those questions sort of on those. Now, next up is Frankie Prendergast, who's the Digital Health Applications Program Manager at St. Patrick's Mental Health Services. And she's going to tell us about your portal, which is the role of the remote care, and the role of the Remote Care User Advisory Forum, and crucially, the service users IT support service. So Heidi and Frankie, good morning.
Good morning, everybody. Yes, today I'm going to provide you with an overview of your portal, the role of the Remote Care User Advisory Forum, and the Service User IT Support Service. So if I just go to the next slide. So just to set the stage, just enabling, prior to enabling remote care, the St. Patrick's Mental Health Services Changing Minds, Changing Lives strategy in 2018 to 2022 recognised the transformation that the new eSwift system would bring, and that the use of technology would be imperative to delivering quality care. It envisioned the future state of internet-based support, and that being used to support face-to-face and telephone care, care provision. Significantly, the strategy also called out that a key transformational factor will be ensuring that service users have access to their own electronic health record. Next. So in 2017, St. Patrick's Mental Health Services, as you know, when you've heard, introduced a fully integrated electronic health record. The system was called eSwift. It uses the access group, what at the time was called ServLec, now called Access Group Provider, and it uses the RIO system as the basis. It also uses a very powerful integration engine called Mirth as the hub of our communications and how we talk to our systems electronically. Through that, eSwift has greatly improved the delivery, safety and quality of healthcare for all our service users. And this is done by providing better access for clinicians to information in a timely way, and while at the same time protecting the privacy and confidentiality of all information within the systems. It enables provision of clinical care and treatment across inpatients and daycare services for both adult and adolescent services. It integrates registration, scheduling, billing, external communications such as SMS, email, and system-generated letters. It also interfaces with multiple applications, including pharmacy, incident management, laboratory, billing and claim systems, as well as their business intelligence applications and MS Teams for enabling the video access to consultations. It integrates also obviously now with your portal, so information shared with and from the service user is shared back into their electronic health record on certain occasions. I'm not going to go into too much detail into the actual functionality, but the key modules that we use are the patient administration, and that includes Mental Health Act administration for admission and management, referral, caseload scheduling, appointment scheduling, bed management for admission, discharge, transfers, therapeutic leave management. Clinical documentation is very much on a basis of what our clinical governance policies and regulatory requirements require us to be able to capture within the clinical record. And that can include the, information during the psychiatric admission assessment, and that assessment can be used obviously both for physical patients coming into the ward and also for the home care patients services. The other areas of the RIO application that we use are the electronic prescribing and the medication administration management. This is also supported with what we call a downtime medication viewer, which means if there was an occasion where we had to take the system offline, for example, to do some maintenance work, it doesn't happen very often, we would have access to the medication information for a period of time while the system might be offline. And that's kind of critical, really, if you're using an electronic prescribing medication administration processes. Other areas that we've implemented is the care planning, so the ability to be able to document multidisciplinary team meetings, facilitate key working activities, diagnosis management, and also the needs-based interventions and actions. The pathology module has been implemented, and that integrates with our third-party laboratory provider and their LIMS system. With the configurability within RIO, it has really enabled us to adapt and adapt quickly as it was in 2020 to implement new forms and mechanisms to support the remote care delivery. And that has obviously enabled integration with all these multiple systems that we mentioned earlier. Okay, next slide, please. So I just, before I move on, I just want to kind of introduce to our digital health team. The digital health team has transformed in the past 6 years, and there's some have been there since the beginning of time in terms of the implementation, the initial implementation of eSwift and the integration with other systems. Some of the rest of us have come along later in the journey. What we do is we provide the applications, implementation and support, as well as technical integration, design, business intelligence to inform operational and organizational reporting. We work very closely and collaborate very closely with our colleagues across the organization to enable user adoption, transformation and training, as well as provide the service user IT support. Our team is responsible for developing the integration solutions design, obviously based on the organization's requirements and the clinical workflows that we need to enable. But our solution design process is very embedded in the end user engagement, and that's the end user engagement both with our staff and with our service users. Our team is very driven by innovation. And I think you'll see that later on in some of the videos that we're going to show. And they also thrive on a challenge. And obviously, we've had a few of those in the last couple of years. Okay, next slide, please. So in keeping with St. Patrick's Mental Health Services' rights-based approach to service user care and treatment, the organisation committed to procure a patient portal in 2019 in keeping with this strategy to enable service users access to key information and the ability to share information and communicate securely with their care teams. Next slide, please. So not going to go through the whole schedule, but just to say we had a plan. And we actually, the schedule to get to phase 1 readiness was agreed through the ICT steering committee and the project advisory group to early 2019. All our target dates were met. And some of them actually came in slightly earlier than planned, which was great. And the outcome of that was the Patients Know Best portal, known as PKB, was selected. Throughout 2019, there was also, in parallel to the procurement work and the likes, was a working group was established to develop a service user, what we called at the time a digital health forum. And we'll cover that a wee bit later on around how that established and the developments of that. The Your Portal phase 1 was in planning. We had some technical enabling design already in play. And we had planned to commence the actual project for phase 1 in mid-March 2020. But obviously that got postponed on the back of the COVID pandemic onset. The project was put on hold, and we had to kind of obviously redirect our focus and our resources really onto the enablement of remote care delivery across the organization. Next slide, please. So what this is showing really is our first iteration of how we try to enable and did manage to enable communications between our clinicians and our service users. Particularly, this is showing how we try enable the ability to send video links to service users, and that the service user and the clinician would join at the same meeting using the same link. COVID-19 obviously accelerated the need for this and drove the need for it. And it was quickly recognized at this time when we implemented this that our service users as well as their staff would require support to use this technology. And that led to the setup and development of the service user IT support team, which you've heard mentioned earlier. And we'll also go into that in a wee bit more detail later. Through all of this, the Your Portal project was on hold. Our first iteration that's depicted here on the slide to enable individual appointments to be accessed remotely worked. However, it was quite a manual process. It did require some duplication of work in terms of booking an appointment in eSwift and also booking an appointment in Outlook and emailing links. But it did work, and it did meet the requirements, and it did ensure that the service user and the clinician could continue to meet and for the care delivery to continue. However, we thought we could do better than that if we had had time. So next slide, please. Now, again, not going into the detail, but Orla had mentioned earlier that we took on a rapid deployment plan for our portal. So on the 15th of April in 2020, the Your Portal Rapid Deployment Plan proposal was presented to the Project Advisory Group. The Project Restart proposal was based obviously on the benefits that the portal could enable to share information securely with service users and support remote care delivery. The deployment scope was revised and the phase 1 plan was reset. Clinical teams, the service user portal design group and the supplier were all engaged, and the phase 1 portal implementation scope was prioritized to include the ability to be able to access appointments and the MS Teams links from within the portal appointment view, and to be able to upload documents into the portal so that service users could receive those documents securely in their portal record, and also the ability for some of the programs to be able to send requests to service users to complete online forms as part of their pre and post program outcome measures. And also then there was access provided and information uploaded into the Your Portal library. The portal communications plan was developed in conjunction with the communications department staff and our service user group. And then from that, service user and staff information, leaflets and videos were developed, and the Your Portal pages were launched on our website in advance of the go live. Our technical design and testing completed successfully, and the benefit of enabling a single sign-on, which meant that clinicians could access a service user's portal record by clicking on a link in eSwift, was successful, and that was enabled. What that means is that only staff who have a role-based access and a legitimate right of access to a service user's clinical record has the ability to access the service user's portal record. There was pre-go live staff training delivered, and the cutover was successful. The portal was ready, live and ready for staff registration to start on the 29th of June. And the first service user registration invite was sent out on the 3rd of July. In parallel, obviously, to that, we had established and set up our service user IT support team. And I say team, and we'll come on to that in regards to what that means at the beginning of the setup of the service. But the key objectives there were really to support video-enabled appointments, the access to those, and troubleshooting any queries that would come in from service users in relation to the use of Teams, and also to support the service user portal sign-up requests, registrations, and any queries about how to use the portal. The registration process for the portal was designed through privacy bit of design, as is all our application designs. A full DPIA was completed for the Your Portal implementation, and to assure that we were GDPR compliant. Service user demographic details are always checked to enable person identity verification before registration would proceed. Communications are sent to service users who are interested in using the portal prior to them registering, so that they can get some additional support with the registration process from SUITS. And then we developed the ability to automatically trigger the creation of a portal record from within eSwift. And what that meant was we could have all the verification checks done using the service users' information, checking with them and ensuring that their demographics, so information like their date of birth, that they had an email address, which is kind of key, but also that their home address and their air codes were recorded correctly and accurately before we would trigger a registration for the portal. If a service user registers for the portal, they can opt out at any time. So they can change their mind. They might not want to continue using. And even if they do opt out, we have procedures to opt the service users back in at any time that they might want to do so. So in terms of registrations, our first year, so that would be from July to January 21, we had about 777 service users confirmed and registered and using the portal. January 2022, it was just over 1,500. January 23, we're up to just over 2,000. And today we've got actually 2,162 service users confirmed, registered using the portal. Okay, next slide, please. Right, now that's a lot of talking about the portal, so I think it's probably good now to have a look at what we're talking about. So we're just going to have a look at the little video.
At St. Patrick's, your portal is an invaluable tool for our service users and our staff. This secure, user-friendly platform allows you to share documents and collect information from service users using online forms. It integrates with eSwift, so all your appointments with service users automatically show in the portal too. All of this supports care, planning and recovery, while streamlining communication and saving time on administration. We encourage you to invite service users to the portal. There are two ways to do this. During an admission or appointment, you can ask if they wish to register and check a box on eSwift to confirm. You can also let service users know they can complete a portal registration form on the St. Patrick's website. In both cases, our service user IT support team, Suits, will send them an email with more on the registration process. Your portal keeps information private. Only the service user, their care team, and those they invite, such as family members or a GP, can access their record. Suits also provides technical support or troubleshoots issues for service users. Your portal greatly benefits our service users and staff. Contact Suits or visit stpatricks.ie to find out more.
Thank you. Next slide. Okay, so we had your portal successful implementation in late June 2020, but in parallel to that, we continue to enhance the ability to manage and access individual appointments to further the enabling of remote care. So that was work that we were working on alongside the portal implementation plan. So in July 2020, we managed to enhance the design. And what this meant was that individual appointments no longer required the duplicate booking in Outlook. Clinicians didn't have to leave eSwift to go to access the MS Teams application. They could do that by clicking on a link in a report in eSwift. It also meant that our service users could receive their MS Teams links from within the portal now, or also via a link that would be sent in an SMS text appointment message. But we still thought we could do better. Next slide. So what you'll see on this slide is the dark blue depicts the old world. The lighter blue depicts where we're at today. So that's all where we have automated the processes. And how we did this was we continued to enhance the ability to manage and access the appointments by automating the generation of MS Teams links and SMS and email notifications through very innovative technical designs supported by within our team, which were based on how an appointment is actually booked in the eSwift record for the service user. So booked, updated, etc., with trigger notifications. This means that everything's kept within the record. You can go back to the next slide. So as part of that process, we in May, that went live in May 22, we enhanced how service users receive the appointment information by launching a new text, email, and your portal notifications. The new notifications are sent out across all our individual appointments for inpatient deemed clinic services, including home care and remote services. The type of notification service users receive depends on which service they're attending and whether or not they're registered to use your portal. It's also it also became possible at this point that if a service user wanted to nominate up to 2 people to receive their appointment notifications in order maybe to support them joining their appointment, that could be facilitated within recording information in eSwift. These developments were based on feedback that we received from service users and how the feedback and engagement with service users has helped to ensure that we've more clear and more efficient way of communicating appointment information to them. The new notifications made it quicker and easier to find information, receive updates, and attend appointments. So in order to do that, we had listened to quite a lot of feedback from service users. Said it was good getting a link in an SMS message, but actually they would have preferred it in an email. So what we have done is combine both. So we still send SMS appointment information, but on the day of your appointment, if you're having a video appointment, you'll receive an on-day email with the link in the email for you to access your video consultation. Being able to choose to include others in receiving appointment information offers reassurance to service users of support in their mental health recovery, and focusing on paperless updates and reducing the number of letters about appointments that is also more environmentally friendly. Next slide, please. So we continue to develop and work with our service user advisory group, and we continue to work with our portal supplier to look at more technical features and enhancements that might enable more efficient communications using your portal. So on the 7th of November 2022, the Your Portal Inpatient project was launched. It's trialing a number of new features in your portal. The results of these trials will be used to test and enhance these features before they might be made more widely available across the organization and across various inpatient journeys. The design and development of these new features came about through collaboration between the digital health team, the portal provider, the clinical teams involved, and the Remote Care Advisory Forum. Obviously, every patient, inpatient and home care service user in St. Patrick's Mental Health Service receives care from a multidisciplinary team. They coordinate and deliver the individualized care which best meets the needs for the individual service user. The MDT, together with the service user, develop a care plan, and that sets out the goals for the person's recovery, along with the supports and the tools that they will help them achieve these goals. So the new features developed in your portal aim to support those service users to communicate as effectively as possible with their MDT and to be highly involved in their care plan. This is in line with our human rights and recovery-focused ethos, which sees us strive to empower service users to control and guide their own treatment and mental health care. Now let's have a look to see what to expect.
If you are an inpatient or in home care with St. Patrick's Mental Health Services, you can use your portal as a key part of your treatment. It helps you communicate easily with your multidisciplinary team or MDT, monitor your care plan, and so much more. At admission, you will be asked to complete a service user expectations form. This outlines your expectations for your treatment and is used by your MDT to inform your care plan. Next, your MDT will assign you a key worker. This person ensures you and your MDT work together on your care plan. To see your key worker, simply go to the Events and Messages section of your portal. Each week, you will have a key worker review meeting where they show you your care plan and share updates with you. After this meeting, you can view your care plan in your portal. Just go to the treatment section and click Plans. Your key worker will also ask you to complete the service user views and opinions form each week. You can do this on your portal. Simply click the link in the email notification, enter your login details, and complete the form. Your responses go straight into your clinical record, and your MDT uses these in their weekly meeting to review your care plan. Contact our service user IT support team, Suits, or check the portal library to find out more.
Thanks. We can move on to the next slide, please. Okay, so crucial and integral to the Your Portal implementations and other implementations such as the notifications processes is our service user portal design team. So back in 2019, we started looking at how we would set that up. So we had a service user engagement and advisory approach developed. There was a working group working within the hospital to look at what the terms of reference might be, how would we engage. So it was agreed that service users from the Service User Advisory Network would be invited to participate in the Your Portal project. And we developed the sort of draft terms and terms of reference and the service user engagement brochure. On the 3rd of December then, 2019, the quarterly Service User Consultant Forum focus was on the Service User Portal project. An overview of the vision and the benefits of the portal and a demonstration of the portal was provided at that meeting. And that was followed by a very engaging Q&A session. Following on then, service users were invited to express their interest and get involved in the project. And out of that, there was a good level of interest, and there were 11 service users signed up to form the very first service user portal design group, which it became known as. Further work progressed then into early 2020 around just developing out the terms of reference and how we work together and setting up a schedule of meetings. But our inaugural meeting was planned for the 12th of March 2020. And of course, on the back of the COVID pandemic onset, we had to postpone that meeting. And obviously, because our focus was shifting from the portal at that stage. But then obviously, we then progressed with the, you can go to the next slide, please. We progressed with the rapid portal deployment plan. So in the 27th of May, 2020, we re-engaged with our service user portal design group, and we had a restart of the engagement process. The key focus then, and obviously we had communications before that first meeting on the 27th of May around, obviously we had shifted our direction of travel and what we were going to focus on within the portal's first implementation, phase 1. But what was key to that was the service user portal design group focused on reviewing the Your Portal registration process to assure its usability for service users, ensure that we were providing adequate information and clear information about that process, and also the how-to guides and how to use the portal, making sure that we're in plain language and we're easy to access and to use. So the go live in June 2020 was achieved through the continual commitment and ongoing encouragement from this group. Next slide, please. So we then, one year, we had another service user consultant forum around May 2021. And in that, the service user advisory 1 year on was revisited, and the portal design group transitioned to become the Remote Care User Advisory Forum, which is still in place today. Some of the original members moved with that, and also new members joined. Next slide, please. So we had the first meeting then after that in May 21, and those meetings are held monthly. The forum is built upon the work from the Service User Portal Design Group and has helped us to achieve enhancements to the registration process, developing more friendly how-to guides, and also improving the library, your portal library structure, navigation and content. Go to the next slide, please. Discussion and ideas that come from that group and feedback into various strains of work, some specifically around our SUIT service, some specifically around how we communicate with service users through technology, and obviously some are focused on how we can improve using your portal. So some of the feedback that we got and we had really fed into the inpatient journey on your portal is the importance of the care team providing information about your portal and how it's going to be used during the care and treatment pathways. This was expressed quite a key for how we could improve the service users' uptake of the portal and seeing the benefits of the portal if it's the clinicians that's having that conversation with the service user. The use of videos, which you've seen some of the outputs of, was seen also to be beneficial and was high on the requirements. That has been proceeding, and we have others available to go up on our website shortly. And then in terms of SUITs, it was the group were very keen that the SUITs team would look at how they delivered the support. And on the back of that, looked at what about a walk-in service, like a regular afternoon walk-in service, and also providing structured tutorials. And that has been taken on, and we're actually working on that at the moment. You'll see that shortly. Other engagements have come through that group are the feeding into other work, such as there was feedback and inputs into the mental health reform project on the digital divides and digital inclusion project, and how these issues might impact access on mental health services, and also into some other research around mental health and remote care technology. Do you want to move on to the next slide? I'm aware of time, so I'm going to speed up. Not taken away from the value of our service user IT team. The service user IT we've talked about, so I'll go quite quickly on this one, but as I said, absolutely not taken from the value they add. It started in April 2020. We had one person who was supporting us for a period of time, along with some of the members of the digital health team as well. By September 2020, we realized that we needed to invest in that team, because the demand on the team to do provide support, certainly for at that point, particularly for accessing MS Teams video consultations, was higher demand than we had the resource at the time. So we recruited at that point one person. That service has developed such that we now have 3 permanent SUITs team members. The initial scope was, as we said, remote care, video appointments, and registration to the portal. But now the team has developed into being much more proactive, triages the daily admissions, contact service users proactively to ask them, do they need support? We also provide service users or on wards devices that can be used for the duration of their stay. And when those devices are assigned, the email for that unique device is available to the clinicians in the service users eSwift record. Those notifications we mentioned earlier, they automatically go to the service user's device. And SUITs then have rigorous procedures in place around clearing down those devices in between service users' usage. And also we have an automated process that allows us to limit the apps that are on that device to those only that are approved or required to enable remote care and provide well-being tools as well. SUITs, next slide, sorry, yeah. So from a SUITs development perspective, as I said, we've taken on board what feedback we've had from service users. So currently the SUITs team present a regular slot at our morning lectures, and that's around providing overviews about the portal and top tips about accessing the video appointments. We're currently developing a number of tutorials that will be provided through hybrid meetings to service users on site and attending remotely. The SUITs have worked with Chime to procure and provide devices to enhance remote care attendance for service users with hearing impairments when they're attending their video consultations on site. And also we've just finalizing the regular walk-in of an afternoon service where service users can drop in that can facilitate just some queries, or also on some occasions we provide printing services for service users who might need some documentation printed out while they're an inpatient. And that's that. And I'm very sorry I didn't do as well as Paul and I've ran over. You're
all right, Frankie. I mean, we completely jinxed it ourselves by going, let's eat up the buffer with questions, so don't worry at all. I'm conscious you'll be back with us, Frankie, later with Niamh Murphy, the clinical nurse manager, to talk a little bit more about the Building Strength and Resilience clinical program available in your portal. So we'll chat to you about that later. Thanks for now. Okay, we're going to move on now to our
Sorry to cut across you, Jan, there. You've just, I'm not sure what happened there. Sorry, you might have to do that again.
No problem. Did Frankie even hear me telling her that we would see her later?
We did hear that part.
Okay. It was bound to happen. Okay, well, we're delighted to welcome our next speaker, who's Krystian Fikert, who's CEO and founder of MyMind, which is Ireland's first and largest blended model of mental health care. Hi, Krystian.
Hello, and thank you very much, Jenny, and thank you very much for the invitation. I will share my screen. So 1 second. I think that should be there. Can I just confirm if
yes, yeah, that's perfect.
Okay.
Yeah,
it looks a little bit futuristic, but yeah, that's the aim of the conference to tell about new technologies and different kind of level of developments. So again, thank you very much for inviting me. And I will start with a short introduction. As my name is Krystian Fikert, and I'm the founder and CEO of MyMind, Center for Mental Wellbeing. I'm originally from Poland. I moved to Ireland in 2004, so it's already 19 years. Yeah, I kind of describe myself as a social entrepreneur, trained clinical psychologist, currently studying blockchain and distributed ledgers. I'm doing masters in completely different field that I'm very passionate about. I'm coding a little bit, and I believe that technology can be very good for humanity. So before we move to the essence of the conference, we all know that yeah, there is a problem in terms of access to mental health care, and highly likely a problem with access to early intervention and prevention services. So for majority of people and across Europe, we can see a lot of specialized services, but not that many community-based services. There is definitely a certain level of improvement. So COVID, that was very unfortunate, that for the past 3 years helped the digital aspect of mental health delivery and healthcare delivery. So what we can definitely see is this kind of a higher transition to early intervention, prevention model, psychoeducation model, and more focus on universal aspect access to mental health care. So to tell you a little bit about MyMind, I set up MyMind back in 2006, and our focus is purely early intervention and prevention. Since beginning, we had this kind of a blended model. Of course, back in 2006, at the beginning of our services, there was very little access to video platforms or even phone counseling. So we had slightly different approach at the very beginning. We had more like a chat-based service or asynchronic even support. But then that was kind of developed to more video and phone call support. So before COVID, our services were at the 90% for face-to-face delivery and only 10% online. COVID definitely drastically changed this, and even post-COVID, as we can see now, we are still at the 70% level of online delivery. And when I say online, is purely video and phone calls. So only 30% face-to-face. We currently have over 200 mental health professionals working with us. So that would be a combination of psychologists, counselors, psychotherapists, and we support 20 different languages. At the moment, we have 5 physical locations that are not that well utilized, I must say. So that's why we're currently looking at different models, and probably it's going to take good couple of years to transition to more decentralized model. But we definitely see that going forward, to keep physical locations is just very, very difficult. So just to give you some recent data from our services and how 2022 looks like, we provided our services to over 6,000 clients, over 42,000 appointments. 68% of them were delivered online. Average age of our clients is 35. Average number of appointments is over 7 appointments. And because during COVID, we had significant focus on supporting clients affected by COVID-19. So that was in tandem collaboration between HSE and Department of Health. That's why there was this significant percentage of clients still affected by COVID-19. In terms of the reported issues by our clients, anxiety is 37%, depression 22%, stress 17%, relationship issues 13%, and some other reported difficulties. Our aim is, of course, to grow further our services this year. Our goal is to provide 55,000 appointments. We'll see if that's going to be possible, because we, as probably most of the organizations, are struggling with the funding. So we currently looking for further funding for either delivery of our free services and low-cost services. But that's our goal for this year: 55,000 appointments, and continue growing our services in the coming years. To access our service is very, very easy. So if you go to mymind.org website, you can just click register, and then basically the process is step-by-step process. And we have implemented triage kind of system that is again step-by-step self-assessment type of model. On this slide, you can also see our AI that is implemented to support clients with various questions about our services and also external services. This is, again, just want to point, very, very simple AI. Yeah, so it's fully controlled by us. There is no implementation of any external models, AI models. At the next few slides, I'm going to tell more about AI. And this is just an overview of how the portal looks like when the client register with our service. So they can very easily book appointments. Through our portal, they can also exchange messages with assigned mental professionals. As we are low-cost counseling model, our clients, they can make payments through the system. If we have any particular projects, like for example, free counseling project, they can redeem codes, they can see tasks that are assigned by the therapist, etc., etc. So, and they have also full access to all the data that we hold, and they can request deletion of the data if that's necessary. So. So that's just a very quick overview of the portal, and now I'm going to show you as well how the video aspect works. So basically, this is just a very short overview. We're not using any third-party software, so everything is happening through our web browser. The clients, they don't need to download any software and can simply click start and have session with mental health professional. And we have, of course, basic functionality like the video call sharing screen. So sharing screen is available only for mental professional. Therapists also can make a phone call if there is any technical difficulty, or they can chat with the client. So in terms of technologies and securities that we use, we have a small team of developers. We have at the moment three developers working with us, 2 senior developers, 1 junior developer. All our systems are built in .NET framework. Mainly .NET Core. We use very secured API connections, especially for video calls and phone calls. So everything is highly secured. All information exchange, or all the logins are supported by 2-factor authentications. All mental health professionals working with us, they have access to E1 Microsoft license. We're not using Microsoft for any client contact, but that's mainly for therapists to contact with us, with our office. So even if they work from home, they can still avail from, they must actually avail from the Microsoft E1 license. For all the machines that we have on our premises, we use slightly more secured license, that is F3. And for staff, we use E3 license, that is again more secured. So the future is very interesting, and I must say I'm very passionate about technology and how we're going to kind of move forward with future delivery of mental health services. So I definitely see kind of a higher integration, or more important role of AI. We're currently testing ChatGPT. So previously I showed one screenshot of our AI that is very basic. That's nothing to do with ChatGPT, but we're currently exploring ChatGPT that is more sophisticated. We're currently exploring DaVinci model to support mental health professionals. Basically with questions related to clinical practices, to integrate as well our database of all the policies and procedures that we have in place, just to give more faster and better access to all necessary support that can be available to mental professionals. We're also testing at the moment a blockchain solution for really future aspects of especially electronic health records. So this is between blockchain itself, our distributed ledger. And we're exploring as well currently a very futuristic option of entering metaverse, virtual reality, and augmented reality between therapists and clients. So this is just very simple screenshot from the basic version of AI. So as you can see, it's kind of busy slide. But again, I just want to emphasize that this is fully controlled by us. So there is no external content that is coming to the AI. We fully trained the AI, and it's very simple. Yeah, so there is nothing super sophisticated. Again, Web3 is coming. So Web3 is the next iteration of the current web framework. So that would be very, very exciting to see all decentralized aspect of service deliveries in the future, and how technology, decentralized technology, is going to play in the future. So we're exploring this at the moment as well, probably in very early stages of the development or exploration, I should say, but it is very, very exciting time. So I would like to leave the audience with the question, how or what is your view on delivery of mental health services in the future, how this is going to look in 2025, 2030, or 2050. Are we going to still use mental professionals, or are they going to be replaced with AI or robots and supported by AI? So this is just open question. I don't have any answers for that, but yeah, it's going to be interesting to hear your feedback. And I'm sure there will be a distribution of the slides. I included some of the references, and if someone wants to contact us, that's our contact information under when you scan QR code. So that's everything from me. Thank you very much.
Thanks, Krystian. That was really interesting, and my jaw hit the floor with that graphic of the back end of the AI. I was like, it's like its own little universe.
Yeah,
but I know you'll be back with us later for the panel discussion,
right.
and hopefully some of our participants will have some things to say about that question that you posed us as well. So thanks for that.
Thank you.
Okay, we're going to move on now to hear from our next guest, who's Lachlan Scott. And Lachlan is the CEO of HealthLink, which provides accessible, free or low-cost mental health services locally, nationally and internationally 7 days a week. Hi, Lachlan, how are you?
Hi, folks, how are you? Thanks to me and Jan for having me on. Yeah, I'll be as quick as possible. I'm going to flick between some slides and our websites just to give you guys a kind of more live version of what we were doing. So I'm just going to put this up here now. So, as Jan said, we provide accessible mental health services 7 days a week for children, young people and adults. We began in 2012 and it became, a lot of the service we provide came from the work I was doing in social work and social care work, and also seeking personal therapy myself, which I couldn't get out of hours. And so a lot of these lived experiences from myself, both work and personal, helped to drive these services that we're going forward. So what we do, we have a range of counselling services for all ages. So we begin supporting people as young as 3 with our play and art therapy services. They're available in Galway and Mayo, and we then have a full suite of other services such as youth counselling, bereavement counselling, couples counselling, addiction counselling, and standard counselling, all available 7 days a week and out of hours, both offline in Galway and Mayo, as I mentioned, but also online nationally. And as Jan mentioned there as well, internationally. So we provide the world's first online counselling service for our diaspora. So basically, if you are an Irish citizen, you're living anywhere in the world, you can get free culturally sensitive support from home. The second...
Lachlan, I'm really sorry to interrupt you, but just your slides aren't actually moving. We're still seeing your first slide.
Oh. Okay.
I don't know if you're using maybe two screens or something. There we go.
Is that okay? Yeah.
That's we're seeing what we do. That slide now.
Perfect.
That's
okay.
Great. Thanks so much.
No problem. So the second thing the second and third services we provide are an information service and an education service all around mental health. I will come to those details just in a little bit, and how we help. So we're client-centered, we're evidence-based counseling services, both online and offline, for mild to moderate presentations. We provide expert and insight-driven, continuously available mental health information education services, provided in the way people want to engage with them. What I mean by that is our e-learning platform, which I'm going to come to now, provides services in the way that people want to engage with them. How we utilize technology. From 2012 to date, we've been providing online services, counseling services. We started with Skype. We quickly moved to VC because of the privacy issues around that. And then in 2020, with the pandemic, VC shut down a lot of accounts. So we had to move, and we moved then to a Danish online platform, video platform called Cara Connect. We're still utilizing that with our online clients, and also with our group work as well. So we started in 2020, we started providing Ireland's only national gambling addiction counselling service, and that became also an additional service to that was an aftercare group service, also online. We're currently working with, I mentioned earlier, we started at age 3, well, we work right up to 103. How we do that, for example, is for older people in our society. We're currently working with Alone on a project in Donegal for online counselling from home for them. And also that's going to be pushing into Galway and Mayo as well, and hopefully further as we go along. The software used with the Alone work is normally Zoom for the pilot, and sometimes WhatsApp if the client prefers to use that, it's something they're used to. So we're all about being about where the client is at. So in 2020, we started building our e-learning platform called MyMind. We developed this with the University of Galway, and it houses our unique digital and video podcast libraries with mental health content, and also houses our continuously available child and youth mental health workshops. And the software in there that we use is WordPress, an LMS system, and WooCommerce. I'm just going to pull this down here for a second and just give you a quick look at the website. So this is our e-learning website here called MyMind. As you can see here, we have the child and youth mental health workshops. We also do live webinars for corporate services, for employees and managers. And these are our podcast and video libraries that are completely unique to the Irish context. You can see here some of the recent videos and podcasts that are on there. This is constantly curated. We have over 800 videos and podcasts from Ireland and all over the world around mental health content, with content for all ages as well. St. Patrick's Mental Health Services, in fact, are up there. Grow are up there. Any podcasts and videos that come from evidence-based sources, we have them up there. When it comes to the child and youth mental health workshops, so we have designed, since 2017, we've been providing workshops for children and young people around building resilience and increasing confidentiality and having mental health life skills. So these actually went online in 2020 with the support of the Irish Youth Foundation. So currently 6th class students all over the country can avail of this workshop either in school or from home, where it helps them to deal with the emotional transition from secondary to from primary to secondary school. There's a short trailer on there if anybody wants to have a look at that. They use the LMS system to log in, and it's available to them for 10 months once they've registered. So it helps them right through the transition from primary into secondary school. When I mentioned earlier on about meeting people where they're at, this is a very good example of this, where people are able to engage with content beyond just a half day or a full day workshop. where you would have actually, there's a psychological theory, the Epicus theory, where you actually, if you are doing something in person, that you can actually lose a lot of that information very, very quickly within 48 hours. However, if you've got access to something where you can repeat things, these things become much more ingrained, such as mental health life skills. And this is the one for youth that we've just released.
Sorry, Lachlan, we actually can't see that website. I thought it was just me, but a couple of our participants said they can't see it either. We're still seeing your shared. I think once you share your presentation to Zoom, it's not going to show us what's on your PC if you're opening.
Okay. So it's a new share. Sorry that I need to do that.
Well, I'm conscious you were maybe preparing to wrap up the part on the website. I'm not sure, so don't, whatever you think yourself.
How is that?
That's it. We can see it now.
Yeah. Okay. So I'll just run quickly through it from the. So this is what I was showing you at the start. This is the homepage. These are the workshops. These are the webinars, the libraries, and there you can see the recent videos and podcasts. And just to go back to that, the reason why we've gone down the non-text route is because all the research that we were looking at was people are much more likely when looking for mental health information online to watch a video or listen to a podcast than to read even past the first paragraph of a piece of text. So once again, it's about meeting people where they're at. People can take their time to look at these in the future. I'm just going to go back now to my slides. Can people still see the slides now?
We're still on the website, there we go, there's the slide.
Okay, and we have future ambitions then to reach over 10,000 children and young people with the workshops by 2025, over 50,000 unique users of the libraries by 2025, and we're hoping to open up, because we provide hybrid services, we're hoping, and the Northwest and West of Ireland are very represented and resourced. We're hoping to open up 3 new satellite offices in Athlone, Sligo and Donegal to cover the whole west and northwest coast. We'll continue then with our online work through developing portals, etc. in the future. And that's really us. Okay.
Thanks, Lachlan. That was really interesting and great to see all those various different hacks. And as you say, it is so important to meet people where they are. So it's great. We look forward to having you back for the panel discussion later, and I'm sure people will have questions or anything about that then. So thank you very much. All right. We're now approaching, yes, we are at the comfort break part of the afternoon, or the morning rather. So we'll be taking a short break. We'll be back at 11:15. We're going to start up again at 11:15. So if you can join us all then, we'll continue on with the next part of the conference, where we'll be speaking to Niamh Murphy, who's the clinical nurse manager, and Frankie Prendergast will be back again, and they'll be talking about the Building Strength and Resilience clinical program, effective remote care delivery within that your portal. So enjoy a cup of tea or coffee, or have just a comfort break. We see you in 15 minutes. Thanks, everyone. Hi, everyone. You're all very welcome back. I hope you got a nice cup of tea or coffee or something to keep you warm, I have to say, sitting listening to all of the presentations. I could feel my toes just slowly getting freezing. So I basically just ran around the place for the last couple of minutes. Anyway, here we are. Our next presenters are Niamh Murphy, who's the clinical nurse manager, and Frankie Prendergast rejoining us. And they're going to discuss your portal, the Building Strength and Resilience Clinical Programme, Effective Remote Care Delivery. So Frankie and Niamh, take it away.
Okay, sharing of the slides is on me this time, so just bear with me.
No pressure, Frankie.
And there we go.
We can see those.
It's
great. Thanks, Jan, and hello, everybody. It's wonderful to be here today and to be part of this remote care conference. My name is Niamh Murphy, and I'm a Dean Clinic Clinical Nurse Manager 2, or CNM 2, and Dean Clinic Coordinator based in both the Dean Clinic St. Patrick's and the Dean Clinic Lucan. Today in this session, I'm delighted to be able to provide you with an overview of our clinical programme, Building Strength and Resilience, or BSR, that is enabled through digital technologies. This is a nurse-led group. It is the first Dean Clinic outpatient group that was developed and is facilitated by the Dean Clinic CNM2s. We are very proud of our group and of its success to date. I look forward to giving you an insight into our remote group today. Next slide, Frankie. So one of the main reasons for developing this group was to improve accessibility to daycare programs to service users who attended the Dean Clinic Galway. Psychology programs were not readily available for Dean Clinic Galway service users. Service users attending the Dean Clinic Galway face several obstacles in attending day programs in Dublin, including the costly commute, having to take time off work, as well as often needing to be accompanied by a family member who then would also have to pay for the commute and or take time off work. The initial aim of this programme was to meet the needs of the Dean Clinic Galway and its service users. However, there was capacity for us to offer places to service users from the Dean Clinic Dublin and Dean Clinic Cork who were on long wait lists for other programmes. The pandemic lockdown highlighted the need for support in adapting to change and self-efficacy. The remote mode of delivery was identified due to the restrictions that were implemented because of the COVID-19 virus and have proven successful enough to continue remotely post-pandemic to meet the needs of the service users who still face obstacles when attending on-site programmes in Dublin. 4 of the Dean CNM2s joined together online in May 2021, which was in the midst of the pandemic and when remote working was implemented. And we designed the Building Strength and Resilience online programme. The Dean CNMs are based in 3 different clinics, the Dean Lucan, the Dean St. Patrick's and the Dean Galway. When creating the group, the Dean CNMs worked remotely and linked in with each other online to build this programme. We worked closely with ICT to develop the online part of the programme as we recognised the importance of using the patient portal, especially as the group was to be online. The portal allowed all information, questionnaires and handouts be delivered to service users securely, directly and instantly. The BSR programme, or Building Strength and Resilience programme, is a transdiagnostic programme. What we mean by that is that the programme is not specific to any diagnosis. There is a variety of different diagnoses within the group. It is led and facilitated by the Dean CNMs, and each group is facilitated by 2 clinicians to ensure that the needs of the group are being met. The programme is delivered online via MS Teams on Tuesday from 9:30 to 1 p.m. in 6-week cycles. A recap group is facilitated 2 to 3 weeks after completion of the 6-week cycle. Our first cycle commenced in November 2021. So the content of the group is aimed at building resilience to promote positive mental health in changing environments, utilising the Podesky and Mooney's strength-based 4-step model to build resilience. The group focuses very much on skills such as CBT skills, DBT skills, including decider skills, mindfulness and solution-focused goals, developing resilience and self-efficacy. The group focuses on the 5 pillars of resilience, which are broken up into the individual topics for each group. They are the introduction to resilience, self-awareness, self-care, mindfulness, fostering purpose, and building positive relationships. To date, we have completed 6 cycles. Our next cycle is due to commence in April 2023. Next slide, please. So the internal criteria, the internal referral criteria. Our group is advertised internally prior to a cycle starting. So we send out a group description to all clinicians within the service via internal email. As Dean CNM2s, we each work with individual teams within the 4 Dean clinics. So Lucan, St. Patrick's, Galway and Cork. We specifically highlight the Building Strength and Resilience group to the consultants and their team when attending these MDTs, making them aware that the group is available to service users who are presenting with difficulty to adapt to a changing environment on poor self-efficacy. We as Dean CNMs also have the opportunity to refer service users to the programme should we feel that the programme would meet their needs as an outpatient. The referral criteria must be met in order to attend the programme. As you can see on the slide, the criteria states that the service user should be between the ages of 18 and 65. On occasion, there are exception made for service users beyond the age of 65 to attend the programme. These exceptions are assessed on a case-by-case basis. Attendees must be outpatients attending the Dean clinics. The referral should be made for service users who are presenting with difficulty in adapting to changing environments and poor self-efficacy. And each service user must be signed up to the service user portal and be able to attend group via MS Teams. Next slide, please, Frankie. So the internal referral process. So a referral is sent to the Building Strength and Resilience RefAssess list through the electronic health record process on eSwift. This list indicates that we received a referral and that we have not yet confirmed whether the service user has been deemed suitable to start the programme. Once we receive that referral, the CNM2 will triage the referral. A screening appointment is booked in with the service user. This appointment is a remote one-to-one appointment with the service user and the Dean CNM2 who facilitates the programme. The appointment is notified in the service user's portal. An example of this notification from the portal is on the slide, the top picture. This appointment is to determine whether the service user meets the criteria or not and is suitable to start the next cycle of the programme. If the service user fits the criteria, they are moved from the BSR or Building Strength and Resilience RefAssess list to the Building Strength and Resilience service user list. So this service user list acts as a hold area or a waiting room. The list tells us that the service user has been screened and are ready to be moved to the final list once we have all group participants, which is 12 maximum, screened and assessed. On completion of the screening appointment and acceptance of the service user to the upcoming programme, we send the BSR information handout to the service user. This handout provides information on the group and the group content. If a service user hasn't already registered for the portal, the Dean CNM will change this preference on their electronic health record on eSwift. This will notify suits. Once the service user portal is set up and we have gathered our 12 service users for the upcoming cycle, we send out the pre-questionnaires which need to be completed prior to the first group starting. The questionnaire is located on the service user portal. Again, the service user is notified when this questionnaire is available to them. So once we have our 12 participants ready to go, they are then moved to the Building Strength and Resilience waitlist. This list is the confirmed list of service users who will be attending the programme and is used to book the service users into each group each week and for outcoming attendance or non-attendance. You can see an example of the 3 different waitlists on the second picture on the slide. And next. So remote group delivery. So this is how we deliver the group online. So a video link is sent to the service users, usually one day before the group is due to start. It may be sent the week before, depending on if it's a bank holiday. The link is sent from the Building Strength and Resilience email. The email will inform the service user of what topic will be discussed, as well as the time, date, and day that it's on. How to access the meeting and suits information is attached in leaflet format on this email, should the service user need to contact them about any access or portal issues. The group agreement is also sent out on this email each week. At each group, we read over the group agreement to ensure the rules of the group will be adhered to. The group agreement or the group contract are guidelines that everyone agrees to follow to make the group a safe place. In order to protect the service user's confidentiality and that of the other group members receiving online group therapy and interventions, each service user must adhere to the agreement. For example, service users must maintain confidentiality of the group and group content, have a private and safe space to work from, have the most up-to-date version of the video link provider, switch the mobile phones off or on silent, no audio or visual recording of the group, no screenshots of the group, and inform staff if disconnecting or leaving the group. Service users are encouraged to keep their camera on throughout the group session. This group requires interaction from each service user, so it's important that each person keeps their camera on. Of course, exceptions can be made on a case-by-case basis. We ask that service users use the raise hand button to ask any questions they may have, or if they're looking to speak within the group. This limits interruption and speaking over other service users and clinicians. It makes the facilitator aware that a service user has a question or would like to share something within the group. When the service user is given their time to speak, the clinician will lower the raised hand button. During break time, service users are made aware that they will need to turn off their camera and mute their mic. The service user also has the option of leaving the group and can be readmitted from the lobby when they rejoin. After the group has ended, the facilitators or CNM2s will outcome the attendance of all service users who are on the Building Strength and Resilient waitlist. A note is written in each service user's electronic health record detailing what group they had attended, how they attended, and whether they participated and engaged in the group. The handouts are then uploaded to the service user's portal. The service user will be notified that they've received these handouts on their portal. If a service user drops out, or if we felt that follow-up is needed with a service user post-group session, a call will be made to them and time given to make sure that they are okay. At times, depending on the situation, we may inform the service user's clinical team about concerns or issues raised with that service user. If a service user does not attend 2 groups, they are discharged from the program. The service user will be notified of their discharge, as will their clinical care team be notified. A re-referral to the group can be made at any time should the service user wish to engage in the future. Slide 6. So the benefits of remote groups for the organization. So a maximum capacity can be facilitated as no COVID restriction rules apply to the group. Improving access to daycare services for the service users, specifically the service users attending the Dean Clinic Galway. It increases access to the Building Strength and Resilience Day programme, offering it from 3 different Dean clinics, either simultaneously or on a rotational basis. It introduces an additional revenue stream for the future development of clinical services. It aligns with the St. Patrick's Mental Health Services strategy to provide mentally healthy living initiatives by developing and expanding the services delivered at the Dean clinics. It broadens the treatment options for service users attending the clinics. It increases accessibility to service users who are unable to attend groups in Dublin due to demographic challenges and commitment limitations. It increased capacity for individual sessions in the Dean clinics as service users who attend the programme may not require individual interventions. It reduces overhead costs, for example, stationery and administration costs. And it reduces our carbon footprint. There is less travel involved and there is no printing of notes or handouts. Next slide, please. So the benefits of remote groups for clinicians. So it offers optimum accessibility to daycare programs for service users from the remote Dean clinics who may not be able to attend other day programs or on other or are waiting for other day programmes. So by remote Dean Clinics, we mean the Dean Clinic Galway and the Dean Clinic Cork. All service users are receiving the measures, questionnaires and handouts at the same time in the same format in the service user portal. This reduces administration work. In other words, time is not lost on printing out handouts, sending them via post, checking up whether the service user had received them, etc. Ease of access to the Building Strength and Resilience Programme questionnaire responses to inform programme outcomes and identify service improvement. The questionnaires will always remain in the service user portal. In the service user questionnaire, the last question asks if there are any topics that you should have that you think should have been included, or if they've got any suggestion or ideas for improvement. We use this feedback to help us improve our programme for each cycle. So an example of feedback that was given to us by a service user was to implement a recap group. We took this on board and incorporated that within our programme. The recap group has been very successful and well received to date. It gives the opportunity to use different tools and formats of providing information during the group. For example, YouTube videos, podcasts. At every group, we show either a video or a podcast, sometimes both, that provides information on the topic that we are discussing. We feel it is important to engage these different approaches. The videos and podcasts are always relevant to the topic. It changes up the format of the group. In other words, stepping away from just talking. Service users have found the implementation of these videos and podcasts very beneficial and encouraging. And all links to these videos and podcasts are referenced in the handouts so that they can, on the portal, so that they can access them at any time. Having a group of 12 participants allows the chance for everyone to share and participate effectively. So everyone has the opportunity to speak and share thoughts without there being a rush. Next slide, please. So the benefits of remote groups for the service users. So it reduces travel costs for the service user and family members who may need to accompany them. The service user can attend the group in the comfort of their own home, making them more relaxed and at ease. Service users can attend the group away from home. In the past, we've had service users who attended the group while they were on holidays abroad. Content, information, handouts, and questionnaires are located in one area, making it easier to access. Service users can access the group by using any device. So for example, by their phone, laptop, iPad. Service users don't need to take the full day off work. They can go back up to work after group, as group is only a half day. And there's less traveling. Receive notifications from the team when the Building Strength and Resilience Programme documents are added to their portal. This happens instantly once something is uploaded to the service user portal. Complete forms online specific to the Building Strength and Resilience group. So everything again is accessed from the portal and is in the same space. And access links to other resources and websites which provide helpful information in the portal library are always going to be there as well. Next slide. So the challenges of the remote group. So the challenges that we faced while facilitating our groups online have been, Wi-Fi issues with service users can cause disruption and difficulty accessing the group. If a service user leaves the group, we do not have direct access to them. A clinician will need to leave the group and try to contact them via telephone call. That is why the importance of having 2 facilitators at the group at any given time. Difficulty in managing slides and videos have occurred in the past, delaying the flow of group. Some service users have found the lack of peer interaction was evident. It was suggested that a peer forum be facilitated during group time for service users to get to know each other. We took this suggestion on board and created a breakout room so that service users can converse amongst themselves at each group without clinicians present. Some service users had difficulty using the tools on the video link, such as raising hands and muting themselves, turning on and off cameras, etc. And when this happens, they were referred to suits for assistance. So this is my part of the slides done. I'm going to hand you over to Frankie now. Thank you for listening.
Thanks, Niamh. Okay, so I'm just going to talk a wee bit about how we engaged with the Building Strength and Resilience team from the digital health perspective and also from the service user support perspective. So the engagement obviously started before the programme's first cycle. The team had already done a lot of work. As Niamh said, they had worked remotely together to pull together the format and the schedule of the programme, and had identified which tools they wanted to have available in the portal. So we worked with the team to design and make the pre and post questionnaires available in the portal, and we worked with our portal provider, Patients Know Best, to support that. The build of those forms, there's a bit of an iteration of that, and that includes the team testing the forms in our test environment first to ensure that they're working, are complete, and are working as designed for the programme. And once that's passed, then the forms were put into the live environment of the portal. Obviously, we provided staff training for the team and how to use the portal and how to upload documents to the portal, how to send the questionnaires, and how to monitor when a service user had completed a questionnaire as well. Because if an email notification comes back to the clinician that requested. So we also worked closely around supporting the team around, the communication processes with the service user, the types of information that we might share in the email that Niamh mentioned earlier, in terms of information, contacting SUITs, and also, not overloading too much information so that SUITs would then take on board a wee bit more about how to use the portal rather than sending too many leaflets out on the email. And then we developed, obviously, the communications between the Building Strength and Resilience team and SUITs, and also ensuring that the service users attending the programme knew about how to contact SUITs as well. I think actually at the beginning we did do a little session with SUITs on a call with the team, and we've identified actually that we're going to do that again and on a regular basis going forward. The first session of the programme it starts about 10 minutes earlier than the actual clinical programme itself, so we're going to use that opportunity to support service users as needed, and obviously the staff that are providing the programme, just using that as an opportunity to share information about the portal as well. So I'm not really going to go over the benefits again because we're duplicating there, but excuse me. So I'm going to skip over that slide. But I am going to show you another video because me and my videos. But this video is really showing the interaction between the electronic health record eSwift and the portal in how the Building Strength and Resilience programme can send the questionnaires. What we aren't showing here in this video is the document uploads into the service users file area of the portal, but that's another week-on-week activity that the team do. So I'm just going to quickly play here.
By using the team caseload report in eSwift, the Building Strength and Resilience team can view the Your Portal registration status for all service users who are to be invited to attend this programme. When the status is not registered, the team can request portal sign-up by recording this in the communications preference form in eSwift. They select yes and save. When this is done, the SUITs team will action this request during their routine portal registration procedures. If the status is showing registration in progress, the team can send an email to SUITs to follow up with the service user and support them with their registration process. Where the status is registered, clicking on the portal link opens the service user's eSwift record. From here, the clinician can then open the service user's portal record. From the Events and Messages page, the clinician can select to send the pre-programmed questionnaire to the service user. They'll click on Start Consultation, choose the consultation and click Start. This immediately sends an email notification to the service user that they have a questionnaire to complete. The service user can click on the link in the email notification, and then they will be brought directly to the form. When they submit the form, an email is sent from the portal to notify the team that the form has been completed. The team also have the ability to send a reminder to the service user who has yet to complete the form. They'll do this by clicking into the form, and down the end, you'll see here there's an option to remind patient. When completed, the team can view the responses here . They also have the ability to download all of the service user responses to enable them to analyse pre- and post-outcome responses and inform service delivery enhancements.
Okay. And finally then, I'm just going to...
By using the team caseload reporting...
Sorry, I'm just going to jump in here and not play the video again, much as I love my videos. So there are some work that's in progress or starting off with the going to be commencing with the Building Strength and Resilience team is looking at some enhancements on how we use the portal within the programme. So we're going to be looking to engage with the team to implement some of the new technical designs that we have implemented and are working on. Some of this is around enabling your portal questionnaires to be requested from within eSwift. So in other words, the clinician doesn't have to click on that link and open the service user portal. So it's minimizing the number of clicks you have and to automate the process from within eSwift for the questionnaire notification to go to the service user. Other things that we're looking at is how the team can monitor from within eSwift whether a service user has responded or not to a questionnaire without having to go to the portal as well. So these are things we've done within the inpatient programme, and we're looking to roll that out across this programme and others. The other thing that we'll be looking at is bringing the responses from these questionnaires into our business intelligence tool called Click. And the reason for that, we will provide more ability for the team to do their data analysis and look at the responses and review the feedback and be able to collate and organize that data much more freely than they can do currently, which is literally they download it in a CSV file and they have to do quite a bit of manipulation on that to make it really readable. The other things that we're looking at doing is those handouts that are uploaded, and because these are going into each individual, so they have to go into 12 service user records per program to every week and upload the documentation. That's great. It's available to the service user within their portal, but there is time and effort from the team's perspective. So what we're looking to do is actually translate those paper documents, information, leaflets, and handouts into an interactive area within the portal, which allows you to view the information, view the videos, the podcasts, enter information, and work on that on a week-by-week basis. So it's all in the portal, and it's an interactive tool that we're looking to use for the program. And then finally, we are, and this is quite new, we haven't really investigated this with any other clinical pathway yet, is around the use of the portal messaging within the portal. So to reduce the emails that are being sent to the service users, and also if we are going to communicate in an email type of way, the more secure usage of the portal to do that would be a benefit to both, from the service perspective and also from the service users security perspective. So that's another piece of work that we'll be working with on the team. So we've got a busy time ahead of us, and that's really it.
I love how you just casually say, that's really it at the end, as though you just described something really simple, whereas we're all sitting here going, oh my God, that was so comprehensive. And you could really see what Paul and Orla were talking about earlier, that there is no reduction on investment in delivering this kind of care. It requires all of the labour that in-person care would require. So that really came across. Thanks, guys. We'll chat to you again at the panel discussion.
Thank you.
All right, our final speakers before that panel discussion are Ronan Devons and John Woods. Now, Ronan is Chief Information Security Officer at St. Patrick's, and John Woods is Data Protection Officer at St. Patrick's. So Ronan and John are going to discuss cybersecurity and data protection considerations in the context of remote care. Hi, Ronan. Hi, John.
Hi, John. How you doing? So who's going first, actually? Is it me or John?
Say you, Ronan.
You can decide.
Okay, that's fine. Okay. Just share here. So can you see the slides now?
Not yet. There we go. Thank you.
You seen them in full screen and they're moving on okay, yeah?
Full screen and they're moving around. Thanks.
Okay, that's great. So I'm going to talk to you about cybersecurity in the context of mental health care. So I'll start with what we did pre-electronic health record, where we are at the moment in terms of what we've done on our cybersecurity journey, and then where we're going next, which is really around compliance, IT compliance, and then some challenges we're facing. So I was asked to put in a glossary because I've talked about endpoints, and someone asked me, was that putting a top on your bio? So an endpoint is really a laptop or a desktop computer on our network, or it could be a server on our network. A lot of my colleagues earlier on have mentioned Microsoft Teams. We are a Microsoft house. We use Microsoft Windows, so we run Windows on our desktops and laptops. Endpoint protection then is software running on our servers and laptops and desktop computers, which basically protects them against ransomware or malware. Patching is basically applying security updates. So when there are known vulnerabilities with Microsoft Windows or other products, Microsoft will release a security update to fix the vulnerability, hopefully before hackers exploit it. And then we apply those security updates to keep our endpoints secure. A network firewall then is a device that segregates the network. So really, it protects our hospital network from the internet, and then we have rules to, for example, allow certain users to access certain websites and block those websites for other users. So, for example, we don't normally use Zoom, so we had to allow some of our colleagues today to access Zoom for this webinar. Then the next thing is VPN, or virtual private network. So we try to limit access to our systems we restrict them from the public internet. So when our colleagues are working remotely, and we have a lot of remote workers now, they connect to their home Wi-Fi first, and then they connect onto our network using what's known as a virtual private network. Multi-factor authentication. So you're probably familiar with that with your online banking. If you try to buy something, for example, on Amazon, and then you get a prompt on your phone from your banking app to confirm that you're spending money on Amazon. And then identity and access management. So that's really how we manage our user accounts as well as our computers on the network, how we grant them permission, and then how we remove accounts and remove access as well. So that's a few just technical terms to run through. So our legacy environment, I joined St. Patrick's in 2015, late 2015. We had already gone out to tender and selected our electronic health record at that stage, but we were on paper. So we had literally filing cabinets of paper records in every ward and stored in clinical records. We had a mixed environment in terms of we were using Microsoft Windows XP, Windows 7, Windows 8 and Windows 10. We had a very low dependency on technology, and we had a very high tolerance for downtime. So I know when I had started working early on in my time at St. Patrick's, we had a 3-hour internet outage. And, I asked, what do we do now? And I was just told, we wait for it to come back. So, and we could tolerate that downtime because a lot of staff weren't using computers on a day-to-day basis. Now, since 2017, obviously, we've deployed an electronic health record, and it's an integrated record with the portal and the various other integrated applications. So we have a critical 24/7 dependency on technology. We've really standardized our environment. So we have Windows 10 across our environment. Since COVID, well, going back to 2019, I think Orla mentioned earlier on that we did about 35 remote sessions back in 2019. We had probably about 30 people enabled for remote work, and it was a case of, some of those people working remotely on an occasional day. Whereas in March 2020, we flipped to remote working. So we now have about 500 remote enabled workers, and we still have about 150 to 200 connecting in remotely from home on a daily basis. So in the past, if you grew up in the 80s, you might remember a TV show called Anything Goes, and it was a bit like that. So we had no patching. We weren't, if there were vulnerabilities and security updates available, we didn't have the mechanisms to apply those, so we weren't applying them. We didn't have any anti-malware in place, or to protect the endpoints. If something bad got onto a laptop, it could basically encrypt data or whatever. We didn't have encryption of our systems. So for example, if a system went missing, if there was data on it, there was no guarantee it was encrypted. There was a limited encryption in place. We weren't doing any penetration testing. So for example, we didn't test our systems to see how secure they were. We didn't have offboarding. So even though we had a head count in the hundreds, we probably had a couple of thousand accounts because old accounts weren't deleted. We had what I would call a black box network firewall. It was very difficult to manage and configure. So some people had more open access to the internet than they should have, which meant that they could get to sites, malicious sites that they shouldn't be able to get to. We had a culture of staff sharing passwords and even administrator credentials, which allows you to do more on systems. And we had very limited monitoring of our systems in place. We had kind of a crossover between staff and guest Wi-Fi in that they shared the same internet line. And we also had staff connecting personal mobile phones onto not the Wi-Fi network for our laptops, but another Wi-Fi network which was connected to our network. We had multiple single points of failure. So I gave the example of an internet outage because we had a point of failure at one place in the internet link. And we had a ransomware attack. So there's probably a bit of stigma attached to that. A lot of organizations might not own up to having a ransomware attack, but it was a reasonably limited attack. It was a user got an email, clicked on a link, some files on the shared drive were encrypted. There was no request for ransom. It was a very small number of files encrypted, and we recovered from backup, and the impact was very low. But it's not surprising that it happened given the way systems were managed at the time. Now, this is really about, I suppose, some of our security journey. So we've done a huge amount of modernization. We've probably got about 100 central servers hosted on premise, and a lot of those are related to the support of the integrated electronic health record. We had to upgrade the entire server platform. We deployed Wi-Fi at all sites so that staff could work on laptops and roam around the other hospital and other clinics. We replaced our network firewalls, and we replaced our network links. We segregated out, for example, our guest and staff Wi-Fi networks, and we increased the network bandwidth, and we added in secondary internet links. So touch wood, we haven't had an internet outage. Late in 2019, I was actually working from home, and there was a Dublin 8 power outage, it was an ESB substation, and our generator kicked in, and I was able to work seamlessly from home without even dropping the connection. So, that's testing our business continuity live. In terms of our endpoint management, we've done a lot. Like I said, we standardized on Windows 10. We encrypt the endpoints. We apply Microsoft security updates as they become available. And we have endpoint protection in place in terms of next generation anti-malware. It's called extended detection and response, or XDR. We've also moved away from bring your own device. So where we had staff with phones on the corporate network, they're now moved to the guest Wi-Fi network. We have a HR process in place around offboarding our staff. I mentioned the virtual private network that staff used to connect into St. Patrick's centrally hosted systems, including the health record. So when staff connect to their Wi-Fi network from home, they then connect into our virtual private network, which means they're getting the protection of our network firewall. And they also have multi-factor authentication. So as well as their username and password, they have to confirm with the prompt on their smartphone that they're connecting into the network. We do annual penetration tests. When we started those back in 2017, there were some high priority items found that we had to remediate urgently. Since then, there's been no high priority items found. Sometimes we might even get a medium, and we got a report back lately with one medium item, but it was a question of timing. We had actually already started the remediation by the time we got the report back. And then the next thing, is security awareness training for all staff. So in terms of our future roadmap, we're looking at a compliance agenda. So we've looked at various frameworks and standards, and what we've settled on is ISO 27001. So if we were to get certified with ISO over the next few years, it will increase our IT budget, but every project that we are undertaking at the moment is basically to address a gap between our current processes and the ISO standard. And we don't really greenlight a project unless it's addressing specific gaps. Orla mentioned earlier on with the cloud first strategy, but I'd say it's cloud first / cloud smart. In some instances, for example, we deal with reasonably niche providers who may not have a cloud offering. So we will have some systems on site for the foreseeable future, but where there is a cloud option, yes, we go with the cloud option. We need to work on automation really to help us with the cloud agenda. And what I mean by that is things like the automation of responses to incidents or the automation of offboarding, whatever. So again, there are automation tools available. Some of the challenges that we're facing, you know, I suppose the changing cybersecurity landscape. So there might have been a perception before that, you know, who would attack Ireland, who would attack healthcare, but we've seen how that worked out, you know. I've been at some HSE presentations and they've talked openly about the attack that they experienced. And, you know, they were talking about still using Windows XP on their network. And it's not really the cost of, you know, €1,000 to replace a laptop or a desktop computer. It's the fact that that's embedded in a €1 million MRI machine. So that's where they're having challenges around upgrading. There's a problem within the industry in terms of headcount and skill set. So I suppose we're a small organization. We can't do everything ourselves. We work closely with partners and security partners. But there is a gap in you know, a shortage of skill set in terms of IT recruitment. It's a challenging environment to recruit at the moment. Another issue is alert fatigue in terms of we have a lot of systems monitoring in place, and some things generate normal, not warnings, but alerts. So it's kind of separating out the critical alerts from the regular alerts that you're getting. And then budget, you know, I mean, in an ideal world, we'd undertake every project and, you know, get ISO certified, but there are, you know, we are a not-for-profit, so we're constrained there. And then just highlighted here, you know, we've talked about the health record a lot, but it's the fact that it's integrated. And again, it kind of ties back to the challenges, for example, that the HSE faced around the MRI machines and Windows XP, that, you know, we have some certain legacy systems in place, for example, and it's not a case of just upgrading one. If it's part of the integrated electronic health record, then that has a knock-on impact across the entire record. You know, a lot of our applications are browser-based, and up till recently, some of them were using Internet Explorer, which Microsoft end-of-lifed last year. So again, it's getting on to support in modern browsers. So we've done that lately as well. And then this is an infographic that came from COVID. So you might remember it. I talked about the various levels of protection in terms of hand hygiene, respiratory hygiene, social distancing, etc. And that, you know, it's the Swiss cheese model. Every layer had holes, but the more layers you used, the better protected you were and the better your position to stop the spread of COVID. So this is a similar analogy for cybersecurity. So you've got things like towards the right-hand side, you've got your incident response plan. And yes, it's good to have a response plan and it's good to have it tested, but in the event of an incident, it may not be possible to always follow the plan. Likewise, you have things like cyber insurance. You know, if you claim on your cyber insurance, you may be compensated financially, but reputationally, the organization may not recover. You know, if you look at the PricewaterhouseCoopers, the PwC report on the HSE ransomware attack, it was as simple as someone at home clicking on a link in an email. You know, that was really what introduced it. You can have your mail filter and your network firewall, and hopefully no mail will get through, no malicious mail will get through to the end user. And if they do, hopefully the website it links to is blocked or the attachment will be blocked. But, you know, if something does get through, all of those levels of defense, really in the circle at the right-hand side, we have the end user. And, you know, that is a challenge. It's if users didn't click on the links, you know, and there are some attacks that don't need any user intervention, but, you know, users are typically targeted and they do get emails, and if they click on links or enter their credentials or whatever. So it's really the concept of building the human firewall, that the user is your last line of defense. And this is where the cybersecurity awareness training comes into play. And then this is just the analogy of the cybersecurity life cycle. It's the Firth of Forth Bridge in Scotland. So I know they now use long-lasting paint, but there was a time when I think the bridge is about 2.5 kilometers long, and they start painting one end, get to the other end and go back and start painting again. And, you know, the patching cycle is kind of the same. You're patching servers, firewalls, endpoints, you get them all patched, and then you're into your next patching cycle again. So it's just trying to stay up to date is probably our biggest challenge. So that is it from me on the cybersecurity.
John, are you there, John?
I am indeed. So I'm just going to share my screen now on the data protection. Can everybody see that?
That's perfect, John. Thanks.
So yes, so I'm just going to talk. So hi everybody, I'm just going to talk about data protection considerations in the context of remote care and how health professionals need to address data protection and privacy concerns. So first of all, just to mention that the data protection legislative frameworks to be borne in mind in regard to data processing for remote healthcare solutions are the General Data Protection Regulation, the GDPR, and the Irish Data Protection Act 2018, which gives further guidance to the GDPR in national law. And so basically, the GDPR, the principles of the GDPR is a principle-led regulation that involves health professionals taking a risk-based approach to its data processing. And just to touch on some of these, the lawful fairness and transparency, so you're processing personal data with a valid lawful basis in a fair and open and transparent manner. And the lawful basis we would use for processing of healthcare data is legitimate interest. And we would have carried out a legitimate interest assessment balance where we assessed our rights versus the rights and freedoms of our service users to ensure we weren't infringing on their rights. We availed of the Article 9.2H condition for processing health data, which was Article 9.2H, and that's a condition of using that. So purpose limitation, you can only collect health data for a specific, explicit and legitimate purpose. And so, for example, you couldn't use that data for health research if you're collecting it just for the provision of mental health care. Data minimization is very important, that processing personal data is adequate, relevant and necessary to achieve the purpose of which it was collected. And accuracy, of course, is hugely important in the context of healthcare. And the St. Pat's have an electronic patient record system, and that's very helpful in data consistency and accuracy and keeping information up to date. Storage limitations is another very important principle, that you only retain personal data for as long as necessary for the purpose in which it's collected. And we would have set retention periods with our vendor for the Your portal, so information is kept for a minimum of 8 years. Integrity and confidentiality in a remote healthcare context is so important, and the data controller or health professional needs to be reassured that best-in-class organizational and technical measures are implemented, and I'll talk about that more in slides. Accountability is basically being able to demonstrate your compliance with all of the above principles, and what we're talking about here is the documentation of your data protection impact assessments, your data processing agreements, your training, your decision on choosing the appropriate platform, and I'll talk about that later as well. So data protection by design and by default, Frankie would have spoken earlier about the extensive engagement with various external and internal groups, and a service user portal design group was set up and a remote care user advisory forum. So data protection by design is all about embedding privacy enhancing features at an early stage directly into the design of projects. Data protection by default, settings must be automatically data protection friendly. An example there would be that we would have turned off the recordings in our use of Microsoft Teams for video consultations, so it was turned off by default. So early consideration of data protection by design default is crucial. It offers better and more cost-effective data protection. Trying to implement these privacy enhancing features when the platform is implemented can be more costly. So moving on to data protection impact assessments, it's very important. Article 24 of the GDPR sets out the general obligations of the healthcare professional data controller to implement appropriate technical and organizational measures to ensure and to be able to demonstrate that processing is performed in accordance with this regulation. And carrying out a data protection impact assessment will assist controllers in implementing the necessary technical and organizational measures, and it will also help in adhering to data protection by design. So we would have had documented data protection impact assessment for the service user Your portal, for eSwift or electronic patient record system, and for the use of Microsoft Teams. So what are they about? They're basically about assessing what information is necessary to collect. Is it proportionate in relation to your purpose? Is it strictly necessary to process this data to achieve a purpose? and very important, is the impact on the individual disproportionate to the purpose. So it's essentially an accurate and systematic description of all the data flows in terms of what personal data will be used and who will have access to it at each point of processing. So carrying out these data protection impact assessments in regards to your portal, electronic patient record, the use of Microsoft Teams, etc., we would have identified and carried out an assessment of all the risks. And just to give you a flavour of some of the risks, first of all, I should talk about the security measures that, for example, your portal, it's very important that we have strong security. Patient knows best as a vendor for that, and to hold all data in the secure, accredited and firewall protected data center in the EU. Information is encrypted, whether at rest in the portal or being sent to and from the portal. All clinical data is encrypted, and the vendor do not have access to clinical data. And there's role-based access control for staff. They can only access information as is required. And of course, the staff portal training and training manuals implemented. So this is giving you a flavour of the security measures. There's a lot more, but we also would have entered into data processing agreements, information sharing agreements, and a data protection impact assessment with the vendor of your portal. So just moving on to some of the risks we identified. It's not an exhaustive list, but it just might give you some idea of what's involved. In regards to the use of Teams, we from our data protection impact assessment, one of the outputs was that we needed to enhance our transparency measures. So we beefed up our privacy notice on the website. We created videos and booklets on the use of the electronic patient record system. We have a dedicated web page on the website for your portal. And I just mentioned we disabled recording on Teams. And just in regard to Teams, some of the risks identified were that service users could enter clinical information in the chat function. So we make service users aware that any information entered in the chat could be shared with all group attendees. Sharing of documents and files was identified as a risk using Teams, so that's not possible. We restricted that, and it's another example of that protection by default. If service user uses a Microsoft Teams account to join a group meeting, then their email address will be visible to other service users in the group meeting. So our preference is for service users to join as guests where their email addresses will not be visible. So the clinicians provide written guidance to service users in advance of a Teams meeting in regard to the risk of their email address being disclosed and request them to join meeting as a guest. Another risk identified.
Sorry to interrupt you, John. I think we may not be on the right slide.
No, we are actually. I'm just going through the identification.
Okay, no worries.
Yeah.
Thanks. Sorry.
Yeah, I'm just talking about the identification and assessment of risks, really. So yeah. Are we on this slide for data protection impact assessments?
We are indeed.
Yeah, good. Okay, no problem. So, so another risk identified was that service user email addresses may be inadvertently disclosed when setting up group meetings if the BCC, the blind carbon copy function, is not used. So training is provided to staff in regard to that. And I should point out an internal policy, technology mediated clinical intervention through telehealth was implemented with the following objectives: to ensure that all functionality is deployed and used in a standardized way across the organization, and also to define the appropriate use of functions of the telehealth applications, and to prevent the inadvertent sharing of personal data or recording clinical information outside the clinical record, which is most important. Some of the risks identified with the service user your portal. One risk identified was a document relating to one service user is uploaded to incorrect service user portal record. The mitigation implemented there was access to the service user portal is through a secure single sign-on link in context from the service user electronic health care record, and training includes validating the staff have accessed the correct portal record by checking the service user portal demographics information before proceeding to add information to the portal record. So it's most important. Uploaded documents can also be moved from the portal record from strictly authorized personnel. Another risk identified was an unknown person or incorrect service user receives an email invite to register to use the portal. So we have ensured that the portal registration process controls include identity verification checks and data quality checks on demographic details, including the email address. A third-party cybersecurity review was performed on potential URL vulnerabilities in regards to single sign-on interface. So they were just some of the, just giving you a flavour. Some of the risks is not an exhaustive list, but the data protection impact assessment is so important when you're looking at a remote healthcare solution. So we detailed that explanation and evaluation of the measures to be implemented to mitigate these risks, and consultation with the organization's data protection officer is most important. So data processing agreements, essentially this agreement provides that the processor will only process personal data subject to the controller's instructions and for the specific purposes set out by the controller. So I would have had extensive consultations with the DPO of Patient Knows Best, the Your Portal vendor, and I would have ensured that the responsibilities were set out in the data processing agreement, data processing contract per se, for each of the data controller and data processor. So we would have ensured that the data processor gave a commitment to its staff confidentiality, which is most important. And obviously the processor must implement adequate technical and organizational measures, which are stipulated in the agreement and detailed quite extensively. And the controller must ensure that the delegated functions of the data processor are not outsourced to another data processor, and that's very important, without the knowledge and consent of the controller. So there would always be prior consultation if they're going to outsource any processing. Sub-processors, as I said, are agreed by the data controller in advance, and they have the same obligations imposed upon them as the data processor. And it's important that the vendor will assist the controller to comply with the data subject rights, for example, a right of access to personal data. If you get a subject access request, they will assist those with any personal data they hold. And after the service has been terminated, most important that either the information is deleted or returned to the controller. We're entitled to conduct an audit of our processors, who must provide all relevant information if necessary. And as I said, we've entered into a data processing agreement, an information sharing agreement, and a data protection impact assessment with the vendor of service user portal. Staff training is comprehensive, is most important as a data protection safeguard. Comprehensive training was carried out for staff for data processing with regards to our electronic patient record system, Your Portal and Teams, etc. We have a suite of data protection policies implemented, and training is provided to all staff so they can understand and apply the principles of data protection in their own work. Standard operating procedures are detailed a step-by-step process when working with the systems. And it's important transparency to staff and how and for what purposes their own personal data may be processed in the use of a remote healthcare solution. So for example, we carry out periodic audits on our systems, and staff are made aware of that. Transparency is very important. That the service user is obviously a key stakeholder in the implementation of remote care solutions. So it's important that we provide clear information to service users that can assist them in protecting their own data. For example, for video consultations, just reminding service users that they could be overheard, if they're in a public area, and if they're sharing devices, we send a family home, that just be conscious that their personal data could be accessed by somebody else. There's no data protection impediment to obtaining verbal consent for the recording of audio visual consultations. It does require a fully informed consent of both parties, and the controller needs to be able to demonstrate that valid informed consent has been given. So for example, you could record the consent being provided. We have an internal policy in regards to audio and video recordings. And just in regards to children, children have the same data protection rights as adults, and there's no data protection impediment to providing remote consultations with children, subject to the authorization and agreement of the of the holder of parental responsibility where deemed necessary. And it's always deemed to be in the best interest of the child to proceed in this manner. So as everyone knows, there's higher protection afforded to children's personal data under the GDPR. So accountability is basically, accountability, as I spoke about before, it's demonstrating compliance with the principles of the GDPR. And so if you're entering into remote healthcare solutions, you need to, for any data processing activities involved, you need to put those into your record of processing activities and document them. You need to document your data processing impact assessments, your data processing agreements, document all your policies and the training carried out, and ensuring you get sign off and training. And codes of conduct, this could be the way forward. The DPC, the Data Protection Commission, have encouraged the health sector and its various representative bodies to consider the development of codes of conduct. And where remote healthcare is concerned, it may well be the case that a code of conduct could bring clarity and certainty for healthcare providers. So we live in hope. With regards to data protection certification, the DPC have also stated it is intended that controllers will be able to seek formal certification of compliance with regard to particular processing operations, which may also be applicable to the practice of remote healthcare. And there's more information up on the Data Protection Commission's website in regards to those. So that is all for me. Thank you very much.
That's great, John. Thank you. And apologies for interrupting you there. I lost the run of myself, clearly.
No.
I was looking thinking, wait, hold on, have they stopped moving? Okay, so we're at the point now in the conference where it's basically time for our panel discussion. So we're going to invite back all of our contributors from earlier, and we're going to welcome Adrian Yates, who is a member of the Remote Care User Advisory Forum. And so we're welcoming back Professor Paul Fearon, who I think might be joining us a little bit later. He did mention earlier he might be delayed, so he'll be joining us later. Orla Gogarty, Krystian Fikert, and Lachlan Scott. Now you can share your questions for the panel via the Q&A box. And if it's for a specific person, please pop in their name so we can direct to the right person. And I'm also conscious that, you know, we may not have enough time to get through everyone's questions. And so if we don't do that, you can email your question to communications@stpatsmail.com, and we'll try and get back to you that way as soon as possible so that your question can be addressed. Okay, so do we have everybody back with us with our video screens on? We do, I think. Okay. Something that just actually, while people get their questions in, one that just popped up there during Ronan's presentation, I think it was, is around, have you designed the future proposed electronic health record for interchangeable data as proposed by the HSE? Have you designed with that future in mind? Orla or Ronan, I'm not sure. Orla, do you want to?
I'm happy to take that question. Can you hear me, Jan?
Yes, perfect, thanks.
Yeah, happy to take that question. And it was a very good question. So way back in 2016, we actually engaged with the HSE directly to see if there was any particular guidance on what the national approach was going to be, so we could align our EHR implementation plan with that. But to be honest, and in fairness to Richard Corbett at the time, he had said it was such an early stage, they couldn't commit to what the national EHR would look like. So we forged ahead. Having said that, we do take a very strong approach to information governance and how our data is captured in our EHR. And I'm familiar with the colleagues that drafted that document, Loretta and Fran and Neil. And there's, you know, it's a very comprehensive literature review, but there's nothing new in it as for us because many EHRs apply the same principles. You know, our Information Governance Committee really focusing on data quality initiatives to improve the value of the data that goes into the EHR and to try and concentrate on the data being as structured as possible, because once the data is structured, then you can use it. If it's unstructured, i.e. in progress notes everywhere, it's hard to actually analyze it. And the other thing to say is that we do contribute to HICWA's consultation, invitations for consultation around their health information papers, and as recently as the draft standards for health information management, we've responded to that, and our processes are aligned with those standards, those draft standards. We are awaiting with anticipation for the health information bill, because to be honest, it's a big gap in our national legislation framework, and with a health information Act, you know, the plan is to have a governance, an information governance entity, which will, you know, enforce compliance around how we hold health information. But without that, we are doing our best endeavour and focusing on the relevant compliance frameworks, which Ronan has referenced and Frankie has referenced as well. So that's really where we're sitting with it. We're trying to prepare as best we can for the health information legislation, and our EHR in terms of interoperability standards. I'm involved in a very interesting group called Dandelion. Catchy name, I know. Dandelion, we're in the process of putting together a proposal into, it's following an expression of interest into Science Foundation Ireland, who will fund we're seeking funding for a health spoke to the ADAPT Centre, which is a Trinity-based innovation centre. And the idea is to actually look at, you know, funded work that allows the exchange of health information for research or secondary purposes with the appropriate governance structures. So we're trying to engage with the relevant organizations that are doing good innovative work in this space where data can be used to the value of the public health.
Yeah, and it's interesting, just as you mentioned there, in terms of what Ronan and John were discussing, with very clear compliance pathways and regulatory pathways around data and privacy and all of those things. It did occur to me, like, the speed at which COVID sort of rendered us developing these things so quickly. You know, is there that gap in terms of compliance and regulation? I mean, it must be a challenge to bring that up to speed. Like, the services are ahead of the regulation effectively.
That's absolutely true. And you can't stop the momentum of innovation in technology. You know, unfortunately, Ireland is a laggard in terms of health technology. There's lots of good work going on, and there's lots of good people working in various organizations, but we do need the health information bill. We do need appropriate investment in our national services. You know, we have EHRs in St. James's and the Rotunda, advanced plans in the Forensic Hospital. I know they've gone through finishing a procurement process in the National Rehabilitation Hospital as well. So there are areas where our organizations that have implemented EHRs, but really we need to get the momentum, because ultimately the EHR is just an enabler of portals, which is really the game changer in terms of healthcare. Because in terms of mental health management, if I have a mental health issue, I want access to my information to help me take responsibility for being involved in my own care and recovery. So that's the game changer. The EHR is a big enabler, and we do need some momentum around it. But in terms of the legislation and the compliance frameworks keeping up with technology, that's always going to be a battle. There's a very interesting consultation process happening at a European level around the digital decade, which is from 2020 to 2030. If people are interested in looking up what the EU expect of member states, it's really about, if they really are expecting EHRs to enable service users to access their own information. And I have a sense that the drivers are not going to be local and domestic or national, they're going to be European.
In so many areas with climate and multiplicity of different things, that tends to be the case. Krystian, we had a question for you just regarding, somebody was interested basically in hearing a bit more about how the chat GPT and the AI bot has helped the provision of care to service users, and if and how it's helped clinicians.
Yeah, so as I mentioned through my presentation, the current version that is available to our clients is extremely simple version and fully controlled by us, primarily providing basic information about the services, when we are open, how to book appointment, how to cancel appointment, about the list of mental professionals. We have also option for emergency contact. So it's very, very simple. I would call it almost like a support directory only. Yeah. So there is no particular engagement, any emotional engagement. So the chat at this stage, and that's on purpose on our side, it's not engaging any in-depth conversations, yeah, because this is not ready yet, yeah, and probably, yeah, we might explore and add more functionalities in the coming months or years, but definitely at this stage it has limited capabilities. But what we're currently exploring is a little bit in-depth support for mental professionals, yeah, and we might engage, we might add this, I would say, coaching aspect for mental professionals, and I mentioned through my presentation as well that we can add the library of various policies and procedures, guidelines, etc., etc. Because again, we realize that sometimes therapists they might have question when they should report a case to TUSLA, etc., etc. We have, of course, our clinical manager answering this type of questions, but most of the time they are very repetitive questions. So we're trying to find a way how we can support our mental professionals to the best, and also allow a clinical manager to answer more in-depth questions rather than these repetitive questions. Yeah. So that's kind of what we're exploring at the moment. So we'll be releasing kind of in-depth AI support for mental professionals that is going to be internal. Yeah, so it's not going to be available to the public. And then if that's going to be successful, and if we're going to have a good feedback from our mental professionals, then we might start releasing some of the components to the public. That will be probably more again in the coaching aspect rather than in-depth emotional support. Yeah, if that makes sense. Sure. Yeah.
No, it makes lots of sense. Yeah, and where those lines are when things get escalated to a different channel versus within the AI area.
Exactly. Yeah. So so that's definitely needs to be further researched. Yeah.
Yeah. Thanks, Krystian. There's a question there for Frankie and Niamh. I'm not sure which of you want to take it, but it's around, you were describing the recap group. That was some feedback from your group about having a recap group. And Michelle is wondering just if you could chat a little bit more about what that looks like, how it feeds into the wider group experience. I don't know which of you want to take it, Niamh or Frankie.
Yeah, I can answer that question. Sorry, I can't turn on my video. Oh yeah, there we go. Hi.
Thanks, Niamh.
Sorry. Yeah, so there is a maximum number of 12 service users that attend the group. So there's 2 facilitators to 12 service users. The recap group involves us basically recapping the 6-week cycle that we had, just covered. So all of the content, well, not all of the content, more the topics that we covered. We just give the opportunity to the service users to ask questions that they felt they might need help on, or that they might have struggled with over the 2 to 3 weeks, or that they'd like more information on. It's mostly kind of like a Q&A with us, that they have that opportunity to kind of converse with us about any skills that they want to go over, so on and so forth. So basically that's the recap group in a nutshell.
Right. Which makes a lot of sense, because when you're in the midst of something and there's a lot coming at you, it can be hard to really have the perspective on it all. Yeah. Oh, actually, I would have liked to have asked more about this, or I'm kind of wondering about.
Yeah, absolutely. Like, we cover a lot of content within the group. So it's a lot of information to take in, and, nobody's going to learn that in one session. So sometimes having that recap group to ask those questions, or to say, look, would you mind just going over this skill again? I did find it really helpful, but I don't know if I'm using it right. Or, I looked at this part of the handout or the group, I'm just struggling to understand it. Could you just go over that a bit? So that's really what the recap group is about. It's to have that opportunity to raise those concerns or issues.
Sure. Desmond has a question here wondering about how much of the practical aspects of the service users care plan are managed and maintained dynamically in order to keep the continuity of care. So Orla, I don't know if that's one for you. Or
I think that's Frankie, I think would be best placed. Frankie. And I'd welcome contribution from Adrian in terms of his experience as well of both the remote care and the portal. But Frankie, I think, would be best place to start answering.
You're up, Frankie.
Sorry, would you mind just repeating the question for me?
No problem. It's basically around the practical aspects of service users' care plans, and if they're managed and maintained dynamically in order to keep the continuity of care.
Okay, so not being a clinician, I can talk a little bit, well, I have a nurse background, but I can talk about how the multidisciplinary teams manage their care plans with the service users. So those are reviewed on a weekly basis with the service user. They're updated dynamically as service users' needs are identified. interventions and actions are either added or you know, resolved. So that's a dynamic entry into the service user's clinical record at any point in time. Any of the clinicians involved in the service user's care pathway will add and update the care plan in eSwift. The sending of the care plan to the portal isn't done on that dynamic basis. It's done as part of the multidisciplinary key worker review. So on a weekly basis, the key worker meets with the service user, they review the goals and, you know, agree goals. And when that finalized output of that meeting, the key worker can tick a box in the electronic health record, and that automatically sends that version of the care plan to the service user. And then that they can have that, and they obviously can look historically back over their care plans over a period of time.
Great, that's really interesting, thanks. I'm conscious just if I'm moving like this, I'm basically going to end up into like, I'm going to need shades at some point, which will bring a completely different vibe to this panel. I'm going to slowly edge this way instead. That was great, Frank. Thank you very much. And I just, Adrian, I'd like to welcome you because you're just joining us now for this panel component. And I'm, you know, you're obviously a member of the Remote Care User Advisor Forum. And I'm wondering, you know, how have your perceptions of what you thought it was going to be like measured up against what it's actually been like accessing remote care or being involved in that?
Yeah, I think that's a perfect question for someone in my position. I think it's, well, this morning actually I did sit in and listen, and you know, what struck me was hearing all the various different presentations, all that went on in the background, because I sat on the forum all right, and Frankie gave us regular updates as to what was going on. But what really impressed me about the development of this is the fact that the patients were actually taken on board. And, you know, there were a couple of references as to the speed and how COVID put pressure on the acceleration of getting these to market, if to use that kind of a phrase. But I'd have to say there was speed, but it definitely wasn't rushed. And I think from our perspective, having monthly meetings, and that wasn't, you know, just for 6 months, there were, I can't remember exactly how many there were, but there were quite a lot. And we had a cohort of patients drawn from all different areas, different ages, different backgrounds. And, you know, I think I definitely have to say, and it's always difficult with Frankie on screen because you kind of think it's like the Oscars or something like that. But I think the inclusion of people and how everybody's opinion was taken on board, and, you know, not everybody is tech savvy. So therefore the word choice comes up very, very importantly there. This is not, you know, a forced road that people as patients have to go down. It's an option if they feel comfortable with doing it. And if they are, there's fantastic supports within the hospital through suits and so on to get you familiar with it. And we were also conscious of it being very, very modular. You know, when some of when Frankie showed some of the, you know, the breakout slides with, you know, the very, very complicated stuff going on in the background. And I think Krystian had one as well. For a service user to tell you, you know, directly to your question, when I go onto your portal, you don't see any of that. And I say that's the credit to the developers and the designers, that it's easy to use, it's easy to follow. Like I say, you can go into much more detail if you want to. And it's quite intuitive in terms of how it works. And certainly for me in home care and so on, getting appointments through your portal, having virtual consultations and so on. I actually did a compassion focused therapy program via Zoom over 16 weeks. And it was absolutely fantastic. And, you know, I just wonder whether I would have been able to do all of that. You remember we were talking earlier about if people are well enough to be discharged, but they still need support, they may be back at work. So how do you get that amount of time off work? Whereas when you can do it virtually, I think it's really, really powerful. And, you know, personally, I see it as just the ongoing development of how we look after people. You know, if you go back when I was first unwell, there were no computers, there were no videos, you know, this wasn't an option. So, you know, we've kind of stepped it through to mainly the clinicians or maybe the experts using the computers and so on. But now everybody has access to that. So I just see it as a natural progression. But I'm really pleased to see that it's in a very controlled, stepped way and bringing people with them. That's what I think is really, really good. And there's huge reassurance being able to see your information. Because again, like the first time I had a stay in hospital, I really hadn't a clue what was going on. And, you know, you're very much, you have that sense that you're out of control from the point of view of you just have to do what you're told and, you know, get on with it kind of thing. Whereas my more recent experience was much more inclusive, much more that I had a voice. And that's now carried that I'm, you know, I'm back at home now and I'm doing my bits and pieces, but I'm still connected in and I still have that access. And now I know, and I can actually research through the library if I'm prescribed something. What is that? How does it work? What does it mean? What are the side effects and so on? So I think it's very, very empowering for the patient. And I think that's really, really important. And then, of course, one of the areas that we've discussed quite a lot is the security. And, you know, it's very, very sensitive information that's been dealt with. So, again, John and Ronan brought us through that. I mean, you know, it's going to be, you know, it's pretty much, we won't say completely bulletproof, but what is? Do you know what I mean, in terms of what we're doing? So, you know, I think of all of that speaks very, very strongly. And I would be, I was wondering when Krystian asked about, you know, where we might be in 2050. I'm wondering if I can still be around. But, you know, I think AI and all of that is fantastic in terms of what it can bring. But I suppose my experience at the moment, and again, going back to the fact that when I first needed support, a lot of this technology wasn't around. But the key thing for me has always been that human connection, that sense that somebody cares about you and that empathy. So I'm not convinced yet. So maybe I'm just a cynic, but I wonder how chatbots or AI things will get around the actual human connection, because sometimes that's so important. You know, the other stuff, if you like, the technical bits about medication and regimes and this, that, and the other, all of that, absolutely you can do through technology. But I think that human piece, I'd be very loath to see it disappear, because I think that's what connects the service user to the service provider. So I hope I didn't waffle on too much there, but you know, it's been a very, very empowering experience. And like I say, it's not something like I felt we were forced into. Oftentimes, you know, I think Frankie might have wanted to kick us and say, why didn't you just disagree with what we were doing? But everything was looked at and came back, and also refreshed every time. You know, whenever we raised issues in 1 month, the next month, this is what we've done so far. You know, even just doing those videos that we saw today, how they would be put together, scripts, this, that, and the other. So, you know, very, very inclusive. You know, so brilliant experience.
I'm struck as well by the fact that when you said about your experience doing a 16-week compassion-focused therapy course, like in the course of 16 weeks, in any of our lives, but specifically when you're in a period of recovery, like there are days where it's going to be much harder for you to get yourself physically into a location to avail of that focus group, whereas it is that bit easier to get out of bed and open a laptop and maybe even still be in half pajamas or full pajamas. You know, there are times where the kind of accessibility of it, I'm sure, is really useful in terms of maintaining that continuity of care over something that is 16 weeks or 4 months long.
Well, it's amazing that you say that, because that actually happened a number of times. You know, you do a little check-in at the start and 2 or 3 people every week would say, do you know what, I probably wouldn't have come on this morning, only that it's online. And, you know, for a while they might have their camera off or whatever. And again, like we all got used to, you know, everybody's very formal from the waist up, but you'd have no idea what's going on with pajamas or whatever else after that. But, you know, people felt very, very comfortable in the group. And, you know, again, as part of support for people who are recovering, you know, you form your own little cosmos there. And, you know, everybody, you know, towards the end, we knew each other so well that, you know, we were really pleased in saying that if I wasn't in this group, I wouldn't have done that, or I wouldn't have been able to do this, or people would come on a little bit distressed sometimes and saying, look, I'm here, I may not be able to contribute as much, but I didn't want to be on my own. I didn't want to miss. So you're absolutely right, John. Yeah, very, very important. I think, you know, people would have given up the course. Like if you miss two sessions or whatever, then you tell yourself, oh, I'm too far behind, there's no point. And you know, you miss a fantastic opportunity there. So, you know, I think it was brilliant the way it worked out, for sure.
Yeah.
Sure.
Well, just to say to you, Michelle has been bigging you up in the comments about what a blinder you're playing in terms of communication to all of us, what the experience was like. And she also did the compassion focused therapy online, and she said it was a beautiful experience. So there you go. And it's interesting, I think, when you talk about maybe natural concerns that people might have about engaging in something that is so intimate, so personal, an area of healthcare that has historically always been delivered face to face. It's natural to think that people would have concerns or trepidation about some aspects of it. But I think, Orly, you had said in your presentation earlier, which I thought was really spot on, that in so much of human development across the whole range of areas of society, you know, it would be wrong to go back to something when we know there are benefits we would be leaving behind. We can actually cherry pick. And I'm wondering, you know, where development is around maybe offering a hybrid model for some things, where maybe, like as Adrian discussed, some days you could maybe just access the group via the laptop, and other days you could go in, and there's that sort of hybrid space where there is an in-person and an online.
Well, you know, there's so much in that question, really, Jan. You know, at a human level, we've come through so much in the last 3 years. And if you think about, you know, the individual personal suffering, the individual need to adapt, the organizational suffering, the organizational need to adapt. And, you know, I think if I'm really honest with myself, even though I work primarily remotely, I go in occasionally to the office if I'm meeting an external organization or person. But, you know, there is a sense of loss that I suppose we don't talk about it maybe on these kind of forums, but I think St. Pat's often, and I've been in Pat since 1995, I know I'm still a rookie, but, you know, there was a familial sense in working together in one physical location. You'd walk down the corridor and you'd have vicarious conversations about something that hadn't been on an agenda of a meeting, or you hadn't seen somebody in a while and it triggered you to ask them something when you met them. And there is a sense that can't be incorporated into perhaps the more formal meetings online. And I do think we need to think of creative ways, and the comms department have done fantastic work with HR around wellbeing activities to support staff to have that sense of continuity, and that technology is embedded into our organizational culture without feeling we've lost something, and have a desire to go back to the pre-COVID days, because those pre-COVID days are gone. Because if you think about the choices that I've just referenced and me being able to work, you know, I had a familial situation where a family member was very sick during the first year of COVID. And if I hadn't had access to working remotely, it would have been a very different situation. And equally for service users, and I think Adrian has just, you know, so precisely captured the power of technology. When somebody is at their lowest and needs support the most, you don't need another barrier to get help. And I think if, you know, we don't want to talk up technology beyond what it really is, but it can actually provide instrumental and critical support at those moments when somebody needs help. And so in terms of, you know, why would we lose the benefits and opportunities that that technology can give us? I do think it is about choice, and Adrian quite correctly has said that. There will be people who do want to return in person, and we have opportunities for those sessions to return in person. We do have the options for people to continue to access care remotely through home care and outpatient day programs. But the other thing I think I referenced in the presentation, we're doing a nice pilot with the clinical psychology department, because they have service users who want to attend clinical group programs in person, but also those that want to attend remotely. Or they might be feeling a bit, they might have the flu and they don't want to come to site. And so we're in the process of procuring technology to allow that hybrid participation, because it's tricky. How do you provide proximity in the group when you've got 6 people in a room and 4 people online? How do you have a shared experience? So definitely it needs to be piloted. We're still learning, we're still polishing, we're still refining, and the service user remote care advisory is so critical to that, and they'll be involved in helping us test some of that technologies with our clinical psychology colleagues. And I think, to speak to Krystian's comment about where is mental health services going to be in 2050, like Adrian, I probably won't be in Pat's, and hopefully, either I'm looking down or looking on. I think choice is going to be critical. We can't stop technology moving forward into areas of newly discovered capability, but what we can do is be open to ideas, and open to ideas of where they have an instrumental value to improving the quality of mental health services, not just in terms of content, but how we can reach people who at the moment are having difficulty accessing care. So whether that's AI or chatbots, I think we have to be prudent, and John and Ronan have talked about cybersecurity and data protection considerations and privacy. They're well embedded in certain sectors. They're very new in the mental health space or in the healthcare space. So I think incremental discovery, incremental implementation in pilot stage and testing, but it needs to be done in collaboration with service users. I think we should remain open, but obviously things have to be tested and proven to have a value.
Sure. Yeah, I actually, in my workplace, we have hybrid options for meetings. And, we're kind of still testing it and how it works best. And the weird thing about it at the moment is the people who are on site are sort of sitting around the table. And then the other people are sort of beamed in by this massive screen up. There's something.
Well, maybe you could help in our pilot.
There's something weirdly Dr. Strangelove about it all. We all feel like we're at somebody on. I'm just wondering, oftentimes at these conferences for speakers, because you're all working in a space where it's, you're all sort of working on different aspects of this wider topic, sometimes you've questions you'd like to ask other speakers. And I'm just wondering, are any of you, like Lachlan, Krystian, Ronan, John, any of you, have you questions for each other, perhaps, about something that you observed in somebody else's presentation? That would be a no.
No, actually, I have a question for Lachlan, because Lachlan and I have met on several occasions and he's really forged ahead into new areas. I'm fascinated by the gambling service that you provide, and how does remote delivery of that service add a particular value into what's a very complex and probably, hidden mental health issue?
Well, we started it in March 2020, literally just as the COVID pandemic hit. We've been talking to people from Grow as well, who had, previous to COVID, the pandemic, had all in-person meetings, group meetings and that kind of thing. And they found that once they went online, they actually got a lot more people involved, because there is still that stigma around accessing mental health support. And you'd have a lot of people, and we've experienced the same thing ourselves with the gambling service once it was up and running, that you'd have people that do not want to go to their local area. They do not want to be seen going into a community hall or whatever it is. But they're quite happy to go online with a group of other people that are from Tipperary, Galway, Kerry, whatever it is, kind of thing, like, and they're happy to work away, and they're much happy to work with. And in fact, we believe, once again, talking with Grow and through our own experiences, that people are much more likely to engage with a service if it is online, especially when there's a stigma surrounding it. So that's been very interesting. We initially, the first 2 years, we just had the online counselling, and then towards the end of 2022, we started the towards the end of 2021, we started the group aftercare service, and that was also a huge support. We started with 1, we now have 6 going, and it's just the attendance to it is regular. That we have hardly any no-shows to it, because we believe partially because it's available online and people can do it from their own home. I also believe right across the board, when it comes to online counseling, whether it's gambling or any kind of counseling like that, some people, for example, if you have triggers in your own home where that are taking place, then if you're addressing those triggers not in the space where they are, I'll get to this in a second. So if you go into a clinical environment and you're talking about the triggers, it can almost take away from what's going on there. Whereas if you're within the space where these triggers are happening and you're getting the therapeutic intervention in the space where these things are happening, it is a much more comprehensive treatment and intervention. The other piece that we've been looking at over the years, how it's very, very helpful, is people with social anxiety. So we'd have work with a lot of people that might have been been out of the house for a few months, and this is also with regard to the COVID piece as well. As we've seen recently, there's a lot of older people that are still afraid to come out of their house. So with that and with social anxiety, we've had counsellors literally in a person's ear. They've brought people down to the local shop. They're on their phone with headphones in. The counsellor guides them down, supports them down to the shop. They do what they need to do. They come back. That's all part of their therapeutic experience. So it is not a panacea for everything. And I'm certainly not a preacher for it. But it does, like people have said today, it creates choice and it empowers the person where they didn't have that power before, and that's the key to it.
That's so interesting. Some of those unintended consequences that we just, when we were all at a race to like, we just need to be able to deliver this stuff remotely because everybody has to stay at home, and not actually realizing what some of the treatments might actually be enhanced. Some people's experiences might actually be enhanced by the fact that it's remote. I mean, just that idea, it's a very powerful image of somebody who has social anxiety being literally guided by somebody in one of these, walking down to the shop. And I can just imagine how much more empowering that is. Like, you're doing it, but you've got the stabilizers effectively of somebody in your ear if you need them.
Exactly. The same thing also for a lot of people in rural areas. We work with a lot of farmers as well. So we have testimonials back from farmers saying, I didn't have to leave the land. I didn't have to change my clothes to go in and dress up. I didn't have to pay for parking. And also the stigma piece as well comes in there. But like we've literally had counseling sessions on a tractor. We weren't on the tractor, but they were on the tractor and that kind of stuff in the barn. Do you know what I mean? So we're really getting, with using online technology like this, we're actually getting to people where and when they want to get the support they need. And that's the key. As I said, choice and empowerment, they're the two key words I would take away from this whole thing.
Have you, Lachlan, been surprised at all by any of the feedback you're getting about maybe further things that may be demanded of, like that there's feedback coming of a demand for a particular service or more of a particular hack that you had from your website? Is there anything that surprised you there, or has it all been sort of in keeping with what you would have expected?
Well, just to speak to the pandemic, we expected the youth piece to become a much bigger problem earlier than it did. It was into 2021, about halfway through 2021, where we really started to see this massive influx of young people trying to get support. They were quite resilient up until then. But then I think when it was just after the Christmas of 2020, the other lockdown came in, and I think that was really the key element, especially for young people who had been quite resilient up until then. So we saw a huge, and that has kept going. We had one youth counsellor at the time. We now have 7. There's a massive uptake, and there's also a massive uptake in our play therapy services for children. Once again, we didn't see that in the first year or so of the pandemic, but then it took off. So now we had 2 play therapists, and we now have 6 again. So there's so much going on in that space, especially for children and young people. A lot of people have gotten, I suppose, from an adult point of view, a lot of people have worked through a lot of their issues. We also saw a massive rise in couples counselling, by the way, when the lockdowns stopped. That was a huge, because everybody, once again, they were being resilient for their kids, they were resilient for each other, and suddenly when they were, okay, you can go back to normal now, they were like, well, hang on, there's stuff here that we haven't dealt with for years, and that's massively come up as well.
That's really interesting, yeah, and it's funny that you locate it at that sort of January 2021 period, which really just was grim. As on a universal level, everybody was like, oh God, that was a tough time, that January. There's a question in here, sorry, just also to say, we've had people just really praising all of you for how great you've been and how much insight you've given and how good your presentations were. So I'd like to pass that on to all of you. But one of the questions, which I guess there'd be an aspect here for John, Ronan and Orla possibly, and maybe Frankie and Niamh, is around just how challenging the change management process was at St. Patrick's, specifically introducing the electronic health record and the patient portal. I mean, there's a lot there because there's a lot of change, and it's a lot of change across a lot of departments. But
I'm happy to take the first part, and maybe in terms of the portal introduction, I'll hand over to Frankie and John, and Ronan can add to it as well. Look, I think it's a really intelligent question, because technology and the disruption that technology can introduce into practice can be painful. Our intention is not to create workplace suffering. We want to actually make our colleagues' lives easier. But in order to get from A to B, there's change required. And way back, because we started this journey back in 2015. And I don't know how many people are on from St. Pat's, but at the very early stage, I remember we had this sort of a fairly torturous process around writing down our as-is processes. What do we do every day? What do we do with the referral? What do we do with a letter to a GP? And all that sort of minutiae, capturing it and documenting it probably seemed like, worthless. But when it came to actually configuring the system so that it was aligned, not just to what we did before, but to use it as a way to see opportunities for improving our processes. So that engagement with the organization was really important so it became an organizational change process, not just a project within an organization. The other thing that I think was really good, and it probably sounds like the boring bit, but was really important, is we had an EHR steering group, which included all of the directors. It was on at 9:30 every Monday morning for the duration of the project, and we had 72 meetings. And my message to my fellow directors was, you attend the EHR steering meeting because you're representing your team, your staff. And if you're not there to represent them, and we have to make decisions, that might be hard to explain later. So everybody was there. And there was a real sense of collegiality and collaboration. There were bumps along the way and we had to work through issues. But I think organizationally, we showed great resourcefulness to implement something quite complex and now to be realizing some of the benefits from it. So change is painful, but if it's structured and if it's steered in a collegiate way, you can actually realize the value of it. So that's on the EHR piece. There was a lot in it, but that's the summary. I'll hand it over to Frankie then.
From a portal perspective, I suppose the initial phase 1 implementation was obviously accelerated because of the COVID pandemic, and our change and transformation processes were not as standardized as they would normally be. And because there was a need to be able to communicate. So engagement was slightly different. What we did learn though was when we did the Your Portal 1 year on, you know, the lessons we learned from that was in our approach, and our approach was very much on a not on a clinical process basis. It was more on a functional basis. This is how you upload a document into the portal. This is how you send a request. And it wasn't really done as the as is to be processes approach in the HR implementation. So we did take a step back, obviously, when things settled down, and we were looking at how we could do the enhancements. So, for example, the inpatient pilot, the work that we did with Building Strength and Resilience group, there was much more clinical engagement in terms of what does that mean for how your clinical workflows are going to be supported, as opposed to the reaction at the time was more around, we need to get communications to your service users, and how do we do that? So I suppose in one way that was a good thing, because there was less resistance to the change. But on the other hand, it did come back to bite in that when you went to look at how we would actually enable end-to-end care pathways, there were gaps in what we had done, say, from our implementation approach and in our training approach really as well. So yeah, so I don't know if that answers the question at all, but we did learn lots from it, and we certainly don't do the knee-jerk reaction to implementations. Thankfully, we don't have to anyway.
No, that was.
I was going to say, Jan, maybe Ronan and John could contribute as well about, because obviously they have to make sure things are done securely and in line with our GDPR commitments. So sometimes that requires our staff doing things that might not be easy.
Going back, like I remember when I started, whatever, in 2015, and we were walking the wards in 2016, looking at devices to see how many were out there and what shape they were in. And if you remember, Game of Thrones was popular, and there was a post-it with Winterfell 2015 written on a post-it, and that was the password stuck to the screen. And you know, you had 30 nurses maybe on a ward logging in with the same account. So it was kind of getting that ownership that everyone needed to use their own account now, and getting people to sign in with that account. And then I think probably at the time of COVID, I think staff really appreciated the flexibility to be able to work remotely. So I think maybe up to them, they might have felt technology was foisted upon them by the IT department, whereas people who, for example, with kids in their homeschooling, or maybe they were vulnerable and needed to be isolating at home or whatever. So, you know, having the technology, and there was sort of more ownership around the individual accounts and the laptops and that kind of thing. And then I think that the HSE attack really probably focused people's minds in terms of nobody wants to be that person who clicks on the link in an email or whatever it is. So I think people became more proactive about contacting us. I've got an email, is this safe or whatever. So I think, you know, it's yes, as an organization, we managed to change ourselves, but I think outside events have maybe helped us in a bit as well.
But I think it's interesting when you referenced 2015, and you mentioned it as well, Orla, in your presentation. Like, thank God you were working on it in 2015, because if the pandemic had just gone boom in February and all the work that you'd been doing for 5 years needed to be done in a fortnight, you'd be in big trouble.
Yes, I was trying to push remote working and tell people that we'd invested in all this technology and we should be making more use of it, but it's careful what you wish for. I didn't ask for 400 people working remotely overnight, but that was what we got. Yeah.
Just to say that I have found working remotely very beneficial. I used to travel up from Carlow every day, and you know, it involves 2.5 hours to 3 hours of traveling. So I just have more time on my hands. It was a better quality of life, but it's actually aided me in productivity as well, because I'm not as tired anymore. I can put in it's been very helpful in that regard. I just find that I can actually do a lot more of my daily works. It's been very beneficial. In regards to change management, it's a very good question from Thomas. I know I had extensive consultations with the DPO in Patient Knows Best, and Frankie has been very helpful in that regard. There's many iterations carried out to data processing agreement and data protection impact assessments, and just gave me a better understanding as well of the processes involved. And the electronic patient record has been very intuitive and helpful to me in dealing with subject access requests, for instance. You know, so we can pull a very extensive subject access report from our eSwift. And that's been very helpful in dealing with subject access, of course.
There's actually a question in for Ronan, I think, but might involve you also, John. is somebody's wondering, did you have an IT platform partner or did you build with an in-house development team?
Well, if it's in relation to the health record, that's a product from a UK supplier. But I suppose in terms of our technology partners, we have certain, they're leading blue chip technology companies and we procure from them. So, we try to limit our number of suppliers, and once we have a good supplier, stick with them really. We have, I suppose, I don't know, maybe Frankie wants to jump in on it as well, but the EHR itself is probably about 10 integrated products basically. So there's various suppliers in the mix. Yeah.
And in terms of the portal, Frankie?
Well, yeah, I would just add to that. Oh, did I go off camera? I don't know.
No, you're good. You're good. Yeah.
And we work in partnership with many of our applications. From an applications perspective, are provided by third-party providers, but we do work very closely in partnership with all of them. But in terms of our EHR, we're very independent and self-sufficient. We have the in-house expertise, we have the tools, and we have the configurability within the EHR. So very rarely do we have to go to the supplier to say, can you help us do this? Possibly sometimes when we're maybe talking to another system, we might need another add-on in terms of our integration, something like that. But we're very, very in-house self-sufficient. From the portal perspective, again, it's Patients Know Best platform. And again, we're probably a wee little bit more dependent on them in that they build our forms for us, and we're not used to that. We're used to our independence within our EHR. So that took a bit of time getting used to, but we have a very close working relationship with the portal provider. We meet on a weekly basis, have done since day one, and obviously they're very embedded in learning from us as well about what their products can do. So it's a very very good working relationship. But all of those are vendor provided applications.
I'm going to come back into the light as human sundial as I am at this stage of proceedings. But just to say that was great. We've approached we're a little bit over time, but just the conversation was so good and the questions were coming in. We just kept going there. But just the last comment I leave to Barbara, who's a psychologist with Rehab Group, and she says, fantastic conference, so much valuable information and super presentations and research update. So that's a massive well done to all of you. So thanks so much for your time, for your contributions, and hopefully we'll have conversations around this topic again soon about all the future trends of the 2050s and all the rest of them, and see how many of us are still here. But, so thank you all, and I'm just going to do some last bits of housekeeping now. So that was, I think you'll all agree, really, really interesting, and it just brings to an end our conference today. So thanks again to all of our panelists, all of our speakers for taking part. Thanks to you, all of our attendees for today, and being so great in the comments and the questions, and really, you seem to be really engaged, which was brilliant. And I hope you found it useful and informative. Just a quick reminder that the CPD certificates will automatically be sent out to any of you who registered for CPD when you were signing up for today's conference. But if you allow up to 4 weeks for receipt of that, that would be great. So that's it. When we sign off on today's webinar, you'll see a little link on your screen where you can share feedback. And we always love to hear your thoughts because it helps the team in St. Patrick's and the communications department to develop content that you're going to find interesting, improve future events. And it should only take a minute or two. So if you could do them a solid, that would be great. That's it from us. I hope you enjoy the rest of your day. I hope you stay warm based on the sun in Dublin 7. If you're here, I would get out into it. And all the best. Have a lovely weekend, everybody.
Thanks, Jan.